Welcome everybody to this NJR Research webinar, and we're delighted to have you with us. Looking at the attendee list, I don't know everybody on the list, so just to introduce myself, I'm Elaine Young. I'm Director of Operations for the NJR, and I'm delighted to welcome you all to this event today. Just to give you a little bit of background, I'm sure that most of you do know about the NJR, and if you hadn't had a lot of background knowledge, that you would have looked us up in terms of being here this afternoon. But just to put this afternoon and our research agenda into context, we are, the NJR, are the largest arthropathy register in the world, and we're very proud of that. We've been collecting data since 2003, and next year is our 20th year. So you can imagine over that period, we've now collected, we have on our database circa 3.2 million records. And over the last 5 to 6 years, we've also been undertaking an intensive audit program of our data quality. And now we are very confident of the quality of that data. So as you can imagine, we have this enormous database, rich database of high quality data. So incumbent on the NJR is to make sure that that's used to best advantage. And principally, everything we do is around patient and public. And we actually have 2 of our patient steering committee members here today who'll be making presentation. But you'll hear that theme over and over because it is our raison d'etre. So with this data, the NJR does a number of functions. We look at implant performance, we look at surgeon performance, hospital performance, and a range of other activity. But one of our key objectives and main areas of work is research. And our strategy is to make that data as widely as possible to the research community. And so we take this very seriously and have done for a number of years, but this is about promoting this even further. We feel that through research and through valuable research that we actually look at outcomes which can inform practice and change practice and encourage adoption of best practice, again, to the benefit of patients overall. So that's a little bit about the NJR and putting the research element into context. So this afternoon is about informing you about how you can access data. It's introducing you to statistical and support requirements that may be needed, about governance arrangements in terms of making application. So you're going to hear from a range of different presenters from the NJR Research Committee, management team, research fellows, which we hope will provide an interesting and informative afternoon. Key to it, of course, is that we also want to hear from you. So in terms of some of the operational housekeeping activity, and I'm sure my colleagues will come in at different points during the afternoon to explain further, but you can submit questions, which we'd welcome to be answered by the panelists. So you can do this by clicking on the Q&A button at the bottom of your panel, next to chat, and type your question in, and you can do it anonymously if you wish. You can also upvote other people's questions by clicking the thumbs up icons, and that will give us an idea of some of the main questions or similar themes. The answers will be either typed back to you, or the panelists will choose to answer them in the Q&A sections of the program this afternoon after part 1 and part 3. And you can actually request to be unmuted. You are muted at the moment, it's listen only, but you can be unmuted to discuss the answer more fully if you wish. At the end of this afternoon, we will, or tomorrow, we'll be issuing a questionnaire which would be really grateful if attendees could complete, just to give us some feedback. This is one of the first webinar events that the NJR has actually held. So it'll inform us about how this event has gone this afternoon, which is important to us, but also how we might improve or better future webinars on different topic areas in the future if this has been successful, which we hope it is. And we'll also be issuing you all as attendees with a certificate of attendance. So thank you again. I hope you enjoy the afternoon, and I shall now pass you on to the first presentation, which will be made by Mark Wilkinson, who is the chair of our research committee.
Good afternoon, ladies and gentlemen. My name is Mark Wilkinson. I'm the chair of the NJR Research Committee. Welcome again to this NJR Research Committee sponsored webinar that will cover how to make applications to the NJR for use of our dataset. I want to thank all of those involved in presenting this webinar today for their contributions both to the committee and to this initiative. To give you a brief overview of the webinar, part one will look at give you an introduction to our research and research agenda. We'll discuss the relevance of the NJR and its research to the general public. We'll give you an overview of the data set, and then we'll talk about how you go about submitting a research application to the NJR. In part two, we'll have some role play, looking at what happens in a regular research committee meeting, and this will be in addition to this, there will be some thematic sessions on particular types of analysis that you may be looking at wanting to do and how you look at linked data sets. And in part three, we'll look at what makes a good statistical analysis plan. We'll think about research governance considerations for any application. Next, how you access the data through the portal, and then finally a fellow's experience of using the NJR data. And then we'll finish up with a Q&A session before closing. So to give you an overview of the research program, I'm going to discuss the resource, what our strategy is, what our research priorities are, who sits on the research committee, and to talk a little bit about our research fellowship program. So the NJR is the world's largest joint replacement register. We collect data on shoulder, elbow, hip, knee, and ankle replacements, and to date we have almost 3 million procedures recorded in our data set. In an average non-COVID year, we add almost 250,000 new records to that data set, and we also collect data on outcomes, including death, revision, length of stay, and patient-reported outcome measures. Our data is linked through a patient's unique NHS ID through to other data sets such as the NHS digital data set, HES, and in Wales, PEDU, for collection of data on PROMs and other outcome measures. This all adds up to a uniquely powerful resource and a great opportunity for people to access and utilize. There are many interested parties in the NJR data, and these cover a broad range of interests. We look at GPs and patients. They have a legitimate interest in the data sets so they can make appropriate decisions about their healthcare. Healthcare providers and surgeons are interested in the data for clinical governance purposes and to look at their performance. Similarly for hospital trusts. Healthcare review bodies are also interested in the data, and these include NICE, CQC, and also the Get It Right First Time team. There are many other interested parties, which include purchase of healthcare and healthcare insurers, so they can look at their cost effectiveness, and not least medical device manufacturers, so that they can generate bespoke implant reports on the performance of their prostheses, but also increasingly now with the introduction of the medical device regulations, this has placed a clear burden on them to show evidence of post-marketing surveillance. And lastly, and not leastly, regulatory review bodies such as the MHRA are also interested in the data so they can look at implant performance, both prior to and after release to the market. It would be nice if we worked in a non-regulatory framework, but the regulations are there for a purpose, to safeguard our data. And so in the normal, in a regulatory-free world, the researcher could ask a study question and make a request to the NJR Research Committee and then get on with their project. But we do have to do this within the setting of key legislation, which includes the common law duty of confidentiality, and also more recently the general data protection regulations, which are now in full swing. There are other levels of control. We have data regulators, data controllers. Data controllers for the NJR dataset is the Health Quality Improvement Partnership, but we also access data that belongs to other data controllers, which is the NHS Digital for deaf data and for PROMS data, and also in Wales, PEDU have this similar function. There are also regulators that we need to consider. There's the Health Research Authority that controls access to approval to data. There's the Confidentiality Advisory Group, which runs underneath the HRA, and also the National Research Ethics Service, if we're doing anything that involves patient identifiable data with or without their consent. Within the NJR, we have data managers who manage the data and access to it, and also an analysis team, which is based at the University of Bristol. Our overall strategy is to maximize the use of the NJR data for overall patient benefit. Within that, we're obliged to protect our research data set, which requires a strong governance framework. And in order to achieve our goals of maximizing use for patient benefit, we have a single entry point for all research data requests, and a single management pathway for dealing with those. Our research strategy is delivered by an expertise-based research committee. We do have an internal activity framework to which our research priorities are aligned, but we also aim to maximize data accessibility so that external researchers can pursue their own research interests. And finally, we aim to promote the NJR's branding, its profile, to provide overall added value to the resource. Turning now to our priority framework, we do have an internal annual research agenda which prioritizes 4 topics per annual cycle for scrutiny. These topics are protected from being duplicated in external research activities. But our principles for external research are that we're happy to researchers to look at any topic that doesn't clash with existing research activities. The research we like to see has to be feasible, novel, ethical, and clinically relevant. But bear in mind that the NJR is not a funding body, and our research is not specifically funded. We don't have a clear budget line for that, and so therefore research activities, data that we share for research, we need to do that on a cost-neutral basis. And we do that through our data access portal, about which we'll speak a little bit more in due course. We're interested in receiving requests for data for research across a broad range of topic areas, and I've just highlighted some of those that are here, but there may be others, of course, right the way through from device technology through to healthy development and aging in patients with joint disease and joint replacements. And we've had several initiatives across this range of different topic areas over the years that the research committee has been running. Turning now to a little bit about data structure and its risk. We see in this illustration here the data pyramid, which has safe data at the top in green and most risky data at the bottom in red. If we look at the data value, its costs, and the amount of risk, we can see that data that is aggregate or summary and may already be in the public domain is of has relatively low risk associated with it, and therefore it has minimal controls applied to it to enable safe access. In the middle tier, which is orange here, we can see this is data that is anonymized. It is at the individual patient level, but the risk of re-identification is relatively small. This group of data is data that is generated by the NJR itself and is not linked to other data sets. And it comes with a moderate amount of risk. And so we classify those as NJR facilitated data from the perspective of data project applications. The most risky applications are those that are associated with potentially identifiable data, and data becomes more identifiable the more it is linked and with other data sets that provides different avenues for re-identification. This is high intensity data, and so we have a highest level of control over giving data access to this for external research purposes. Talking a little bit about the application process, this is started by submission of an external expression of interest through the website, and it then gets reviewed by a management team within the research committee, and we either allocate it down one of two pathways. It's either an NJR, a supported project where they're accessing NJR only data, or an NJR partnership process where you want to have access to data that is linked to other data sets such as PROMs or other NHS digital data sets. And they each go down a separate pathway, but both are evaluated within the research committee. And if subsequent approval is granted, you get access to the data through the data access portal. The data access portal is our mechanism to maximize safe access to the data for external researchers. You access the data on your own PC in your own environment. You have a login to get access to the central data resource. We give you access to a bespoke data set, so it only has the data that is relevant to that which you've requested access to, and we can monitor activity centrally to ensure the data is being used for the purpose for which it was requested. You get access to this single clean data source, and you can use a variety of software packages through the portal to conduct your research. This includes Stata, Python, and a variety of other software packages. And you can also request that you could run bespoke scripts on the data set. We quarantine any outputs before you get access to them if you want to download the outputs of your research. And this just makes sure that we're not releasing data on individual patients. It's part of our governance process. We have the data access portal so that we can maximize our capacity to service a whole number of data requests at any one time and reduce our delivery burden. There is, however, still a delivery burden on maintaining this system, and so for this we do charge an access fee, although this is relatively modest compared to access fees for data access portals for other organizations. So who is the research committee made up of? I'm its chair, as I've outlined at the beginning of this talk, but it's also populated by a variety of other members of the NJR. We have the NJR Central team represented here. We also have representatives, surgeon members from a variety of different constituencies. Shoulder, elbow, hip, knee and ankle surgeons are all represented on the committee. We have a strong patient representative presence. We also have some corporate expertise from our past research committee chair, and also members who cover other domains such as health economics, engineering, our regional clinical coordinator chairman, and also contractors from our data management team at NEC, and also our statistical analysis team at the University of Bristol, who also help advise on how to optimize research applications. I'd lastly like to finish off by talking for a few moments about our research fellowship. This is a 2-year rolling fellowship that is a joint initiative between the National Joint Registry and the Royal College of Surgeons. We appoint 1 new fellow in each year, and we have had 10 fellows to date, covering a broad range of topics from shoulder, elbow, shoulder, hip, knee, and ankle. And fellows come from all across the United Kingdom. They're not focused in any particular centres. The 2022-23 round is currently open with a closing date of the 2nd of February. So if you're interested in the Research Fellowship, please contact us through the portal and put in your application. So just to summarise, the NJR Research Committee is here to maximise availability and use of the NJR data, not only for the NJR's purposes, but also for external researchers. Our aim is to promote internal and external access to the data, whilst at the same time observing clinical governance requirements and safeguarding patients' identities and their data. We have an expertise-based committee that oversees the research activity that goes on within the NJR, and we have a particular interest in developing research training of surgeons. And finally, we want to maintain promotion of NJR brands and outputs throughout this process. Thank you very much for your attention. So following on from those brief introductory comments, we're now going to move into the next section, which is the importance of patient public involvement throughout the study life cycle. There'll be 3 presentations, 2 from our patient representatives and a 3rd from our Director of Communications.
Hello, my name is Gillian Coward. I'm a patient representative with the National Joint Registry, and I'm here to talk to you today about things that you already know a lot about. Affection for the National Health Service is deeply embedded in our national identity. Wellness, good health, and longevity are a huge focus in society. And the clue is in the name. The NHS is a service for all its users, including you. And I'd like to keep saying, are you asking questions that are important for us? Are you listening to our reflections on the care we have experienced after surgery or treatment? Since its creation in 2002, the National Joint Registry itself has used research output to publish in its annual report and to inform patients and update us in a range of publications used in primary and secondary care settings, as well as more recently on the website. Other national agencies, the National Institute for Clinical Health and Excellence, for example, also spend time consulting with a range of key stakeholders, including the public and patients, to establish what is important to patients, their relatives, and their carers. They publish regularly updated guidelines. Most recently, these are the kinds of things that they published as patients wanting to know when they approached or had to face joint replacement surgery. They want their guidelines to make a difference to people who might need a joint replacement by making sure that we get good, balanced information. And establishing this quality of understanding leads to that ideal scenario of shared decision-making, where care or treatment options are explored in full, along with the risks and the benefits. Now, patients realize that orthopedic research in particular can be complicated and technical, that it can be difficult for researchers to embed and involve patients and the public in each and every aspect of the research cycle. However, it is possible to bring us along with you by being better communicators. Your application to use National Joint Registry data will be on a data access request form. And I think I've read about 150 of those in the last few years I've been sitting on the research subcommittee. I would encourage you to communicate better the value of your research to patients by paying attention to the lay summary sections of the DARF. In a good lay summary, imagine you have fallen into conversation with somebody with no scientific or technical knowledge of joint replacement whatsoever, someone on a train, an elderly relative you get sat next to at a wedding, and they ask you what you're working on. Can you outline it clearly? Can you keep focused on the benefit to us all? Finally, I'd like to underline that the National Joint Registry relies on patients consenting to their data being used. It may be wise to reflect that the public has become increasingly aware and a little suspicious of data for sale or uncertainty about how it may be used. Researchers should reflect on the importance of their role in the continuation of this contract of trust. Well, that's a wrap, a bright pink wrap in this case after my recent ankle arthrodesis. Thank you very much for listening.
Involving patients and the public in research is about giving them a say in research undertaken, and that research activities are relevant to the people that research affects, and where research is carried out as an active partnership with or by patients and members of the public, rather than to, about, or for them. When referring to patients and the public, we include those with relevant health conditions who use or are affected by health or social care services, or those with relevant experience or interest. So, patients, family members, carers, past and potential health and social care users, as well as people from specific communities and from organisations that represent people who use services, as well as members of the public with experience or interest in research subjects. So why involve patients and the public in research? They can provide a different perspective to researchers. They can bring expertise, knowledge, and lived experience. Researchers may not have first-hand experience of the subject being researched. They may have different views on outcomes not considered. They can help improve the quality of research, ensuring its relevance and priorities reflect the needs of those it will affect. And it's morally right to involve those which research will impact. Three terms are used to describe ways of interacting with and including patients and the public in research work. Involvement, where research activities at different stages are carried out with them and not for them. Engagement, where research information and findings are made available and shared. And participation, where people take part in a research study. PBI, which increasingly has an E at the end, means patient and public involvement and engagement, and is the approach of actively including patients and the public in different activities of a research project. The term doesn't include for participants. Research projects may not have study participants. They may be animal, lab-based, or a review of past research. Co-production is a more recent PPIE approach, which emphasizes researchers, patients, and the public working together, sharing power and responsibility, respecting and valuing everyone's knowledge, and building and maintaining relationships in an inclusive way across the entirety of a project. Patients and the public can be involved across the research process at different stages of what's identified as the research cycle. Certain types of studies, due to their nature, can be a challenge to provide a range of PPIE activities across this research cycle, such as a data study, for example, using NJR data. including for a range of activities, increases research value and outcomes for meaningful societal impact. In setting a research question, individuals can complete questionnaires, surveys, and interviews, and people can attend meetings, workshops, and focus groups, which can be used to help identify and inform research priorities. A research proposal can be shaped and developed again through people attending meetings, workshops, and focus groups. The design of a study with research proposals and protocols can be developed with people to ensure relevance, feasibility, outcomes, and identify any issues. They can help with monitoring and managing aspects of the research process and beyond project committees. They can help with ethics and data protection aspects with approval, consent, and practices. And also with any data requests and applications, such as to the NJR, any cohort recruitment and retention strategies for participant studies, and developing research tools such as questionnaires and surveys, also for participant studies. Any approaches and applications to those funding and commissioning research can be undertaken with people helping to connect to those setting research priorities and funding. They can help with developing funding applications, with writing lay language sections, setting PPIE plans, and having co-applicants or collaborator roles. In undertaking and managing a study, people can help and support the project and research process with developing detailed protocols, producing any patient-facing material, and conducting interviews and surveys, for example, with participant studies, and with producing research updates in lay language. In analysing and interpreting results, people can help ensure relevance and quality to meet project intentions and outcomes, help translate findings with interpretations and conclusions to be understandable for a range of audiences. When sharing research findings, people can help with dissemination plans and methods to reach and be understandable to a wide-ranging audience. They can contribute to co-writing journals, newsletters, and presentations, even co-presenting at conferences and talks. To implement research, people can help with its translation into use through guidance, support, and use of influence with networking and lobbying, for example, with policy and decision makers to affect acceptance, adoption, and take-up. The impact of PPIE can be monitored and evaluated for a project, with people to learn what worked and what didn't, and to be shared and disseminated for others to similarly learn and benefit from. PPIE needs to be meaningful and not a token gesture, being integrated across the research cycle at different stages where possible, and not as a tick box exercise to satisfy any requirements, and with those involved in PPIE being an active partnership to ensure a project has maximum relevance, impact, and benefit for patients and the public.
Hello, my name's Deirdre Taylor. I'm Associate Director for Communications and Stakeholder Engagement with the National Joint Registry. Continuing the theme of patient and public involvement in the research cycle, I'm going to focus specifically on dissemination. So when and how to think about it? Well, to create the greatest impact, dissemination really needs to be considered throughout the study. It's ideal to co-develop your dissemination strategy with the patients who are involved in the study. Robin has talked about the different elements of input they can have along the way, and thinking about how that will all be disseminated is fantastic at the start of the project. You can get to know their skills then and the networks that they're involved with, and who the influencers are and what organisations they interact with, and what policymakers, what commissioners they may meet with. Patients and the public bring with them a really diverse range of skills and an alternative range of relevant networks, including patient organisations who have a very extensive reach. So how to engage patients? You can invite a range of people to review your lay summaries, as has been covered already, in the different parts of the report that you're writing, to ensure that they are understandable. You can involve patients and the public in summarising the research findings in clear and accessible ways. You could ask them for help in clarifying the messages. Are your messages patient needs driven? As Gillian mentioned earlier, do they address in a clear way the advantages of your research? Are they understood easily? You can ask them also to have a part in the research project, an active part in sharing the work. Could they co-author a paper for publication or write part of the report? Adding a lived experience really enhances your work. You could invite those who you've involved throughout the project to speak with you at conferences or seminars, or to make a short recording on Zoom for you to present during your own presentation. Lived experience is really powerful. Telling a story about an experience can help explain why a piece of work is being undertaken and then bring the findings to life by describing their impact on a patient's health and well-being, or on their experience of healthcare or social care services. Teaching and giving seminars and including that patient story gives more impact and creates memory. You can give 1,000 stats and figures that might soon be forgotten, but a story can stay in the mind forever. Drafting a press release for the media and including input or a strong quote from a patient can mean all the difference as to whether a mainstream journalist is interested in producing an article based on your work. Social media platforms are a really great way to share messaging and outputs in a very cost-effective way, either through your own social media, sharing and tagging other people and patient organisations, or through patients' own personal accounts, or through the organisations that they have links with. If you put something on LinkedIn and you've got 500 contacts, and those 500 contacts, some of them like it and their 500 contacts see it, then your messages are going really, really widely out without much effort at all. If you use a short video, it can make more of an impact than a link to a paper. Good bite-sizing messaging for social media and websites is very shareable. And if you've got the patient story incorporated in that, all the better. If you use relevant hashtags, they can create a lot more traction and make it easier also for patients to find research on specific hashtag topics. How could your research benefit from involving patients? Well, it can improve the dissemination process more widely due to the dedication and influence of those involved. You can help reach more diverse scientific and lay audiences. You can improve the translation of the research by using language and messages that are more easily understood by a lay audience, and increase the power and credibility of your message to raise the profile of your research. And it could improve the likelihood of your research being continued, adopted, or implemented. How can it also have a positive impact on you? Well, it's likely to improve your own ability to write in plain English. It can enable you to learn more mixed media methods of talking about and sharing results and be more creative in the way that you do that. It could increase the prominence and relevance of your public and scientific profile and potentially gain greater public interest and recognition for your work. But also remember to consider, do you need to offer any kind of training or mentorship or IT support to enable a patient to partake in any dissemination activity? Could you offer some kind of thank you or reward to show your appreciation for their time so freely given? The NJR website's a very good place to share positive outcomes to reach the public and patients, as well as other interested stakeholders. And remember, the public and patients are interested in reading about your work. It's using their data often. So please make it accessible to them. If you put a paper in a journal that's behind a paywall, they're not going to be able to access it. So please think about the ways that they can share in understanding your positive outcomes and fantastic work. Thank you.
Thank you very much, Gillian, Robin and Deirdre, for those insights. And just another note, if you have outputs that you want to share from your NJR analysis, you can always let the NJR communications team know, and we can post them on the NJR website as well as your publication to given journals. We're just going to move on now to an overview of the NJR dataset, which is going to be given by Jonathan Evans, who's a former NJR Fellow.
Hello there, my name is Jonathan Evans. I'm an academic clinical lecturer down at the University of Bristol, and I was the NJR Fellow from 2017 to 2019. At which point I did my MD, and I've used the NJR dataset for a number of things. There's some research using purely NJR, but I've also got experience of linking it to other databases to answer slightly wider research questions. So today I'm going to be talking to you about two things. Firstly, an overview of the dataset to tell you what data are available to you, but then go on to talk a little bit more about what makes a good research question, how to have success from your research. But in reality, although this is the order I've been asked to talk at, actually very often you'd be better off switching this round. Now, the reason for that is not all questions are necessarily best answered with routine data such as the National Joint Registry. So it's important that you find out what question you want to ask first and then decide if registry data are appropriate before you then go on to look at exactly how you're going to answer that question. But we'll stick to the planned order, and I'll start off first of all by telling you what data are available. Well, the National Joint Registry is best thought of as two parts. The first part are the core data. They're the things that are routinely submitted to the NJR as part of the mandatory national audit. And in addition to that, so those things, part of the core data are who's the patient, when did it happen, when did the operation happen, and what implants were used, and all of those things. And that then can be supplemented by other databases that we can then bolt onto the NJR, or link, as we like to say, to give us further, more detailed information about patient comorbidities, other admissions to hospital, etc. And we'll talk about those add-ons later on. So the first part of this talk, I'm going to be mostly talking about the core data themselves. So what are the core data? What data are available for you to do research into the National Joint Registry? Well, essentially it's this. These are the minimum data set forms, or MDS forms as we refer to them. And they're essentially the checklist of boxes that you'll all be well used to filling out in theatre or seeing in theatre or afterwards. And they tell you everything that we've done during the operation and everything we need to know about the patient themselves. So if you want to know what variables are available, you simply need to go and look at these minimum data set forms and see if the information you're after is written on it. Because if it's not on there, then you either can't use it, or you'll need to find something else that is on there to use as a proxy. So these are all available on the NJR website for you to be able to download and browse to see if the information you want is there. But unfortunately, it's not as simple as just looking at the most recent version of the MDS to decide if that information, if there will be sufficient information to answer your question. So many of you will know that over the years of the NJR, we've used multiple different forms, or MDS forms. Started back in 2003, where we were only collecting data on primaries, which was then subsequently added in revision. But if, for example, you wanted to look at shoulder and elbow information, then you need to be aware that those data are only available from 2012. But in addition to this, there have also been subtle changes within the minimum data set forms themselves. And it's really important that you look into this and you understand exactly what data are available for which time periods. And some good examples of that are things like this. So, for example, at the beginning, we collected data on whether tourniquet were used in knee replacements. So if you wanted to see the association of tourniquet use with revision after knee replacement, then you have only got the data that were available for the minimum data set forms where this was collected. And this is subsequently continued with the addition of other things, such as in the most recent data set, debridement and implant retention, which is now formally assessed. Things like cement in cement revision and case complexity, which was only available in the earlier MDS. So if you want any of these variables that may or may not be there, I suggest the first thing to do is have a browse back through the minimum data set forms, but also hold in your mind that not all hospitals switch on exactly the right day, and you'll still get dribbles of people using old minimum data set forms reported later. So you know what variables are available, and you know what you want to use. But the next question you've really got to ask yourself is, just because it's there, am I going to be able to use it? i.e., if it's on the form, is it going to be collected well enough for me to be able to use it? Now, a good example of this is BMI data. If you wanted to do a paper, as I have done, at looking at the effect of BMI on outcomes following knee replacement, then it's really important to know that although we collect the data and in its form, it makes sense, are they completed well enough that actually they can do the job that they're needed to? So you need to really understand, are the data completed sufficiently, so in enough patients, and is it consistent, and do we think it's accurate? So that's a real challenge, because without the data set, how are you going to be able to check whether those data are sensible? Well, it's a really, really important question. And there are three main ways that I would suggest going about this before you set out requesting NJR data. Firstly, you can submit a formal expression of interest. This is, you can see the way to do it either through the NJR website or it will be explained today. Now, by submitting a formal expression of interest, someone at the registry will be able to look at the question you want to answer, and they'll be able to tell you that there are sufficient numbers of people with those hip replacements, with whatever it is you're after, to be able to answer your question. But before you get this part, it may even be worth a more informal expression of interest, talking to someone that you know has previously worked in that field, asking them, I'm interested in doing this question. Do you think I'll be able to do that using registry data? Try not to be too worried. We're not in the interest of stealing people's research ideas. It's more we want to help and support people to get the best use of the data possible. But anecdotally, what I found is actually just looking at what's previously been published is a really good way of saving yourself a lot of hassle. A good example of this, not with the NJR data, but with HES data, health episode statistics data, is I'm recently working on a project using a combined NJR HES data set to look at periprosthetic fracture. Because I want to look at what fractures happen that aren't recorded in the NJR. Now, I spent a year working on this and banging my head against a brick wall and really struggling. But actually, if I'd read in detail Alex Bottle from Imperial paper that was published a couple of years ago, then he quite clearly says that there are major problems with doing this. So if I'd read that and got in touch with him, then I probably could have saved myself a lot of hassle over the last year. So my suggestion there is read about what's out there already and what other people have done, and get in touch with them before you go requesting data itself. So the next question, you've decided what variables you want and you're going to ask for the question, do you get the whole database? And this is something that you often think, well, what if halfway through I suddenly think I need something else? Will I be able to have the whole database to just decide? Well, in short, no. The NJR won't give you the entirety of its database. They'll give you the information that is specific to your question and relevant. And that's really important from a sort of data governance point of view. So when you go through your research request, you'll be asked to fill out one of these. And this is a spreadsheet that goes through every single variable that's collected on the NJR, and you will need to say whether you need it or not and why you need it. And it's really important that you justify why you need it, so that down in the future, we can look, or someone can look back and say that you did ask for it and that's why you wanted it. But what about hospital and surgeon details? Well, are you going to get all the information? Who performed exactly which hip replacement, which hospital it was in? Well, in short, no. If you were to have that full information of de-anonymized data with surgeons and hospitals, there's a risk that either people could look into questions that weren't necessarily what they wanted, but it's generally not fair and it's not ethical to give people the entire data set. So be aware that you'll need to look at exactly what information you're going to get and know whether that's relevant for your question. So I talked earlier about other databases and how we can supplement the NJR. Well, this is something we call linkage and is an incredibly useful tool. So as I said earlier, we've got the core NJR data, and that's what you would find on the minimum dataset form. But you've also got the add-ons or bolt-ons to this. Now, the first and most important one is the Office for National Statistics. And the reason for this is, unless you know whether a patient has died or not with their hip or knee or shoulder or elbow replacement in situ, you won't be able to make any estimates about the survival of the implant. So first of all, that linkage is normally done for you, but you need to make sure you ask for it, of whether a patient has died or not. But sometimes there's information that you might want and is key that isn't on the MDS forms. So how do we go about that? Well, fortunately, you can link to these other data sets. Hospital episode statistics tells us every single patient that's gone into hospital in England since the start of data collection. And you can link to see how long were they in hospital, what comorbidities have they got, all the things, lots of things that aren't on the NJR. But it's really important that you are aware that you will need to ask for this data separately from a different organization, and you'll need to have the skills in order to link the two databases. One of the big criticisms of the NJR is often that work from the NJR is very focused on implant survival and patient mortality. But if you want to know how well a patient is doing themselves, there are resources out there to look at patient-reported outcome measures. But again, it's another data set that you will need to then link to the NJR in order to get your results. And so to go over again, these are available, but you will need an extra permission, potentially extra funding to get the data set, but most importantly, expert advice on how to link the data sets accurately. I'd like to finish the section on data with just a quick note. Always check the data before you go analyzing it. It's a relatively simple statistical premise, but this is an example from one of my recent projects, is when you just look at the whole NJR, although there are lots of safeguards in place and lots of data checks and sense checks, remember that the NJR has evolved over many years now. So there are some patients that might exist in there that had their hip replacement before they were born, or had a knee replacement after they were over the age of 110, which is probably not feasible. Sorry, that bottom box is in the wrong place. What it was meant to highlight was non-unique prosthetic constructs. So this is where a patient might have 3 femoral stems that all went in at the same primary operation. Most likely due to people sticking more than one sticker on the form. But if there are, you don't know exactly which one ended up in the patient. So unfortunately, we need to exclude them. So it's always worth doing some basic checks of the data before you carry on. And the best people to talk to about this are people that work with the data regularly or have done previously. So now I'm going to move on to talk about what makes a good research question. And this is split into 2 parts: the subject of what you want to research, and then the actual design of the question. Now, when it comes to the subject you want to do research into, I'd actually take it further back to think about, what are you trying to achieve? Now, we all do research for different reasons. Some people just want to get publications. It might just be for their CV, for their training. It might be to achieve requirements for completion of training, or it might be because you want to hit the media and make a splash. But that is very different to someone who might want to specifically do it to help patients by influencing nice policy, nice guidance. And the way you'd go about designing that question may be very different. Or you may just be a clinician who genuinely doesn't know the answer to a question, and you want to know whether I should start doing that or should I start doing that. And so you really need to, before you go into this, be clear in your mind of what are you trying to achieve with your research question. But more importantly, and this is what I say to researchers who come to me asking to do research, is do you think anyone else is ever going to ask the same question and then look up your research paper? Because if they're not, if no patients and no other surgeons are ever going to want to look at your question, why bother doing it in the first place? If it's not going to impact care, impact practice, then it's probably not a good use of resources. We often talk about smart aims in particularly audit and QI, but it applies to research as well. You need to be very specific with the question you're going to ask, and we'll talk about that in a second. But you need to know, can I achieve it with registry data? And is it relevant to my patients and to me? So that leads me on to the design of the question itself. Well, as academics, we all come back to the same 4 letters every time we're reviewing a paper, writing a paper, designing a research question. And those 4 letters are these, PICO. You absolutely must write this down for your research question before you start designing it. Otherwise, you'll come unstuck later on and you'll really struggle. So the P stands for population. These are the people that are going to be included in your study. And you need to be very specific as to who they are. Are they adults or children or everyone? Okay, so adults undergoing hip replacement. Okay, great. But what's the indication? Adults undergoing hip replacement for solely osteoarthritis. Okay, and when? Okay, adults undergoing hip replacement for solely osteoarthritis between the years of 2007 and 2015. So this population, you need to write out very specifically what you want, because you need to decide this before you start doing your analyses. Otherwise, you'll come into problems. Secondly, intervention. What's the intervention that you're interested in? I might be interested in knowing how the extra V40 femoral stem performs within the National Joint Registry. Okay, so you're saying that very specifically, but you're saying exactly what you're after. The extra V40 femoral stem, which sizes, which offsets, or is it all of them? Is it when used as a primary, used as a revision? So you need to know exactly what your intervention is. And then you need something to compare it to. So your comparator might be all hip replacements using a different stem, or all hip replacements that use any stem, or all hip replacements in total. You need to be very clear as to what you're comparing your intervention to. Finally, probably the most important, is the outcome. Are you interested in the survival of the hip replacement itself? Are you interested in mortality of the patient? When it comes down to survival, are you interested in aseptic stem loosening? Are you interested in revision of the stem? Are you interested in revision of the cup? Or are you, as our patient group tells us, interested in revision of any part of the construct for any reason? And you need to be very clear on this before you start designing your question. What we don't want this to go into is a fishing expedition, where you have a big database and you keep asking it different questions until you find something interesting, because that's bad research and it will invariably give you the wrong answers to the wrong questions. But most importantly, what makes a good research question is patient involvement. People have said to me previously, but how do I involve patients? They're not interested in the big data set. Well, I would say that's just not true. We've worked with patient groups in many different capacities, and they are interested. You need to ask, but they're not just interested in the design of the question, but also how do you disseminate the information? How do you spread that information? If you've done a question, you need to give the answer to the patient so that they can make shared decision-making. You need to involve patients in all stages of your research, from the planning stage to performing it, to interpreting the results, and to dissemination. Unfortunately, there have been there are patient members in these talks today who will be able to give you more information on that. But the last thing I'd like to say is, are you sure that registry and routine data are the correct way to answer your question? Or are you just doing it because it's a tool that's available to you? And that's why, going back to the beginning, I'd suggest design your research question first, and then decide if registry or routine data are the best way to answer that. So if you have any questions, I'm very happy to answer them via email, via Twitter, or pick up the phone. But thank you very much indeed for your time. I hope it was of some use, and look forward to working with some of you in the future. Thank you very much.
So thank you very much, Jonathan, for that excellent overview of the data set. We're going to move on now to Rachel Brophy, who's going to talk about submitting an application to conduct research using the NJR data.
Hi, my name is Rachel Brophy, Research and Governance Programme Manager at the National Joint Registry. I'm going to guide you through the process of submitting an application to conduct research using NJR data. I hope to break down the process into clear stages to encourage you to submit your application. Before you begin your application, we recommend that you undertake a couple of checks. First of all, take a look at our NJR research portfolio available on our website, which is an up-to-date list of our currently approved projects. The Research Committee aim to avoid overlap with any approved projects and their proposed outcomes, so it's a very important step to check this before starting your application. Also, take a look at our data available publicly via the annual report, also on our website. If the data you require for your project is available here, you don't need to go down the route of submitting for Research Committee approval to use this data. So what data to request? NJR data is available for England, Wales, Northern Ireland, the Isle of Man and the States of Guernsey, all joining at various time points. We collect data in hips, knees, ankles, elbows and shoulder operations, also joining the NJR at various time points, so please bear these in mind when requesting your data. You'll be given a primaries and their outcome spec, and also revisions and their outcome spec. We can also link revisions to primaries. Within these specs, the data fields will be listed. You'll select the ones you require for your analysis, and please only select those that are absolutely necessary to conduct your project. You'll need to give clear justification for each requested field. Shoulder patient-reported outcome measures, or PROMs, are also NJR data. The NJR has been given permission by NHS Digital to sub-license their data to approved applicants. So we will be able to link hospital episode statistics, or HES, PROMs in hips and knees as part of the National PROMs programme, and civil registration mortality data, which is useful for mortality outcome analysis or implant survival analysis. We can also provide cause of death if the justification for this is clear within your project and the spec. So the linked data will be listed in the linked data spec provided to you. So here you'll also need to clearly justify all fields requested. Linked NHS Digital sub-license data is available to applicants in England and Wales only. And please note that HES is collected in England only, so linked PROMs and civil registration to HES is only for English data at the moment. So the process for research applications is the same, whether they're external or internal. External projects are where you're requesting aggregate data only or just NJR data. And internal projects are where you're requesting sensitive or identifiable data, or linkage to external datasets or sub-licensed NHS Digital data. For internal projects, you'll require a collaborator who is a member of the NJR Steering or Research Committee, and you'll also need to attend the Research Committee to discuss your application. Both external and internal projects follow the same route of approval, so Research Committee approval, and then HQIP, who is our data controller, approval prior to data release. The first step is to submit an expression of interest via our NJR Data Access portal website. Here you'll complete basic details of your project, the title, applicants, co-applicants, and please be clear whether you're requesting review of an external or internal project. You'll receive the outcome of your expression of interest review within a month of submission. If you're invited to submit a full application, you'll be sent the DARF, the Data Access Request Form, which is our application form. where you'll complete further details of your project, ready for a full submission. You'll also be sent the data specs at this point, and the terms and conditions of data release are at the end of the DARF. If you're requesting NHS digital sub-license data, you'll also be sent extra contracts to sign. If you're new to submitting requests for healthcare datasets, please take a look at the HQIP resources, Understanding Health Data Access, available on their website, which are really useful in guiding you through the process. Specifically for requesting NJR projects, when you complete the DARF, I'm going to give you a few tips. So the principal investigator or PI should be somebody with a substantive contract with the host organisation. If you're a student, you would need an honorary contract, but you wouldn't be the PI. Normally that would be your supervisor. When you're completing the methodology, please give clear indication of the background to your project and references. You'll need a detailed statistical analysis plan, which has been formulated with a named qualified statistician who is part of your project team. Please include a sample size or power calculation in order to give significant conclusions. You'll need to demonstrate patient and public involvement in either the development of your project or, importantly, in the dissemination or interpretation of the results at the end of your project. The research committee will be looking out for this when reviewing your project. Pay attention to the lay language used in your lay summary. This should be understandable to anybody from any background, and you may consider running this by somebody with a background from a different subject area to yours, just to make sure it makes sense. To give you an overview of the timelines from expression of interest to full approval, it's different for every project, but the process can take around 3 to 6 months generally. So when you submit your EOI, expression of interest, you'll receive a response within a month. If invited to submit a full application, you'll need to do so by the deadlines which are listed on our website. They're usually a month ahead of the quarterly research committee meeting. You'll need to submit by 5 p.m. on the deadline day to research@njr.org.uk. Your outcome from this will be received within 1 week following the research committee meeting. If you receive an approval from research committee, your project will be given a governance review and then be submitted to the next HQIP Data Access Request Group meeting, which are held monthly if they have capacity to review your project. So it could be one following that, but each meeting is held monthly, and then your outcome is received within 1 week following the DARG meeting. If approved by DARG, you'll receive an invoice which will need to be paid prior to data release. Take a look at our cost recovery policy, which is available on the NJR website. But as an example, research requests from individual non-commercial applicants for NJR data alone would be £1,200 plus VAT. For NJR data plus linked data, so HERS and PROMs, this would be £2,400 plus VAT. If your dissemination is via the data access portal, which will be the case in most applications, there's no charge. All your processing would occur within the data access portal prior to quarantine of an anonymised data set, which you could then download if approved by the NJR team. But if your circumstances mean that you require an extract, this would be an extra charge of £500 plus VAT. All requests also will have a £250 plus VAT DARG review cost, which will be included in the NJR invoice. These rates are different for commercial applicants. As mentioned, please do take a look at the NJR cost recovery policy to give you an indication of the costs involved in your project, but you'll be given a number on receipt of full application. Following approval, your dataset will be prepared and uploaded to the data access portal, where you'll be given access to your pseudonymized dataset. We request that you submit an interim report at 6 months and then a final report at the end of your project, and these will be included in our NJR research portfolio on our website. For any publications that result from your project, please include the disclaimer as listed on the website. All authors must be listed, and an analysis from the National Joint Registry should be included in the title. Please send these in to research@njr.org.uk, where they'll be circulated to Research Committee. You have 10 days to comment, and this should be ahead of your submission for publication. If you have received an extract of data, we'll request a certificate of destruction at the end of your project. I hope I've made the process clear, but if you do need any help or clarification, please do get in touch with me with my contact details listed here. Thank you.
Thank you very much, Rachel, and to all the speakers in this segment. We've now got a few moments for Q&A. We are running a little over time, so I think we'll keep these relatively brief, and we'll focus on the further Q&A later on in the afternoon. So just to summarise a few of the questions that we've had in so far, thank you to all the questions and the responses that we've had thus far. So in answer to the first question, yes, we are going to make the whole webinar available so that you can dip in and pick out various extracts from the NJR website. We've also had a few questions around the issue of linkage. And I wonder if I can invite Rachel to talk a little bit more about the process for requesting linked data and how we actually operationalise that.
Yeah, of course. I did write an answer, but I'm happy to say it as well. And I do want to check with Claire that it's absolutely correct, the linkage process. But I know that you get your NJR dataset and your NHS digital dataset both within the Data Access portal. So here you'd link on one of our pseudo identifiers. So I believe it's NJR ID.
Yes, it's the NJR index number
Great.
that is common to both tables of data. We have a table of NJR data and a table of HES data, and the NJR index number appears in both.
Thank you. I'm glad that was correct. Yes, so then you've got your two linked data sets, and then PROMs and civil registration are linked to the HES data set.
Thank you very much for that, Rachel. So we had another question, which was, does a research proposal need to be submitted for access to NJR data for an individual hospital study, as well as national level research study? So if I could just answer that very briefly, I think if you just want access to your own generated data and your own outcomes within your hospital, then you don't need to ask the NJR for permission, because it originally is actually your data. But it depends who that request is coming from. So if it's coming from the hospital, then they speak on behalf of all the surgeons in the unit. But if it's coming from an individual within a unit, then you have to get agreement from if you want to look at individual surgeon level data from within your unit, then you need to have a permission from all of the individual surgeons whose data is being released. They're happy for it. Of course, if that request comes from the clinical director of the unit, that such permission is not needed because it's taken as read. However, often when you have data that you're requesting about the activity of an individual hospital, you may want to know about revisions that have gone on outside of the hospital. Well, that's okay as well. If it's within the UK, you don't need to have specific permission for that, as long as all the individual surgeons involved in the primary surgery actually give their permission. So that is the central key point if you're wanting data from an individual hospital. But as soon as you want national data, you have to go through the NJR system, provided it's not, if it's just simple aggregate public domain information, then there may be an easier route to do it than using the NJR research request approach. Just looking to see it through other questions, we had several about patient and public engagement and involvement. They've been already addressed. A brief question about imaging data sets. None of the members of the International Society of Arthroplasty Registries, that covers Australia, New Zealand, all the Scandinavian countries, UK, etc., none of us hold imaging data sets. We only hold record level activity. Access to HES, we've already responded to that. I think that takes us through now, I think, to our short break. We'll have a 5-minute break and then we'll reconvene at 2:25 to continue on with the programme. Thank you for your attention at the moment. Welcome again, everybody, to part 2 of this NJR Research Committee webinar. In this segment, what we will be doing is demonstrating to you an example of a pre-recorded mock process for the Research Committee meetings to get an understanding of what happens when an applicant comes to the Research Committee to discuss their project and what happens during that decision-making process. So I'll pass you over now to the pre-recorded interview episode. Welcome to this mock application process for review within the Research Committee. I'm Mark Wilkinson and I'm joined by a number of members of the NJR Research Committee. We're going to give you an example now of what happens during a Research Committee when we review an application where we've asked the applicant to come and present their proposal to the committee. This happens typically when we have an application that involves data that requires linkage from a variety of sources, and therefore it's in our more sort of complex application category. So simple applications where there is no linkage to external data sets, we don't usually have a process of talking through the project with the applicant. But in this case, we have. So here is an application which is titled an exploratory descriptive analysis of 5-year survival of total ANCA replacements compared with equivalent rates in administrative data sets with further adjusting for covariates from Toby Jennison's group. So just to briefly outline this project to the committee. So here the applicant wants to look at the outcomes of total ANCA replacements, and they set out in their background that there is some lack of clarity over what the survivorship of ANCA replacements is, because there is perhaps a degree of underreporting to the NJR, because many ANCA replacements that are revised may be converted to arthrodesis, where a A2 form may not necessarily be completed, and a small number may also result in amputation, in which case an A2 form may also not be completed. And they compare our registry data with that of the Swedish register, which suggests in broad terms a revision rate of around 17%, although the time frame is not indicated in the background that Toby's given. So he's then gone on to propose a linked project between the NJR dataset and that of HES from NHS Digital to look at the overall failure rates across a number of different indications. He's also planning to look at other complications and other medical issues that may occur in the post-op after primary ankle replacement. And the analysis that they will perform are some descriptive analyses and also some Kaplan-Meier survivorship analyses and Cox regression, looking at different factors which may result in differential survival. So that's a brief outline of this project for the committee. Before we get Toby in, I just wonder if we can have a discussion within the committee as to what areas we may like to cover. So I'll throw it over to open to the committee to suggest areas that they may like to raise with Toby.
Mark, I was I was quite interested in the data that had been requested, because it sounds like he believes the HES data is an essential component to this, but he's requested data that also is outside England. So I think really, if HES is an essential component, then data should have only been requested for England. And similarly with the kind of grounds for doing it, it seems very much this is to help inform decision making. But the HRA tools supplied, he's indicated that the data generated would not be generalizable, but they intend to use it in a generalized fashion. So I think we just need to make sure that the HRA and what is being proposed are concordant. Okay, thanks, Michael. Mike, Reid, you've got your suggestions.
Yeah, I mean, the point is picked up actually in a few of the comments from the other reviewers, but the incidental mobile bearing replacement, I thought, was an odd thing to be firstly excluding, and secondly, I don't know how you'd tell if it was incidental. And unless I'm mistaken, that is an operation.
Yeah,
I'm not sure people would see it as incidental if they were having it. Presumably, it's been preceded by symptoms and some admission even before the operation. So I guess I'd like to just explore that a little bit more.
Great, thank you. Andy?
Yeah, mainly the sample size calculation. So he's made an attempt at it, looking really at model overfitting and number of events and degrees of freedom. I'd want to get a bit more of a feel for what size of difference he's expecting in terms of revision rate between groups, and also how things might change if, when he links to HES, the actual revision rate is a lot higher than expected, and how that might affect things for him. Sure. That was something that I was interested in picking up with him as well. The power calculation is not really just describing the effect sizes that he's anticipating to detect between different risk covariates. Robin.
Yes, I'm quite interested in the patient benefit and how the results from this are going to be presented to the patient. It talks about that it's looking at the area of patient consent. So whether that's just going to be, is expected that will just be a verbal conversation from surgeon to patient, or whether they'll get to see something that's a bit more meaningful and tangible to them. So whether it may be something that's visual. And then also, because I like this work quite a lot, whether it could potentially lead into something else, or some sort of tool that could be used in the future.
Great, thank you. And Gillian?
Yes, very similar to Robin. As a patient representative, I feel that I want a clearer outline of how the public benefit could be explained. As a person with an arthrodesed ankle myself, I'm aware of how difficult it is to get information. And yes, at the moment, it's suggesting that this is going to inform shared decision making, better information, but it sounds to me like the clinician will tell the patient rather than the patient being able to find out for themselves.
Great, thank you very much. Okay, so it sounds like we have a range of things that we want to ask the applicant. Rachel, can you ask Toby if you'd like to join us now? Afternoon, Toby. Welcome to this research committee meeting. I'm Mark Wilkinson, the chair of the research committee. We have a number of members from the panel with us today, both lay and expert members. Unfortunately, we don't have you on video as we normally would have because of a little technical glitch, but such is the way of many things. So just by way of outline, could you just tell us a little bit about this project, some background to it, and what you actually plan to do?
Yes, of course. So what I'm planning to do, the title for it is an exploratory descriptive analysis of 5-year survivorship of total ankle replacements. So ankle replacements have been around quite a long time, but the number being performed has about doubled in the last 10 years. Despite this, we don't really know the long-term outcomes, as most of the papers published are short-term or even case series. Also, when an ankle replacement fails, unlike a hip and knee, it can be changed to either ankle fusion, replacement, revision ankle replacement, or unfortunately an amputation. And therefore, we think that the NJR isn't getting all the ones that are failing. So the main aim of my project is to link NHS Digital and NJR data to find out what the true failure rate of ankle replacements is.
Okay, that's great. Thanks very much for that outline. I'm going to hand over now to our panel members to ask you a few questions about your project. So I'm opening it up to the floor now, and whoever wants to go first.
So, Toby, just to start off with kind of the way that you've described the project in the application, you've indicated this isn't research, it's a service evaluation. And I assume that's on the basis of the HRA decision tool you submitted.
Yes.
Saying it wasn't research. So within that, one of the options you've selected is that this information wouldn't be generalizable. But from what I understand from your application, you're intending to use this data to better inform discussions between surgeons and patients to help their decision making.
Yes. So completely, it was using with any application using the HRA guidance to find out, and it's gone through all the approvals. So it's gone through the S251 non-research, and it can only be interpreted from the ankle replacements that have been used and in this situation and in this country. So it can't be into different circumstances be looked at. And the main aim is evaluating the ankle replacements that we've put in and finding out how much they are actually failing or not, because at the moment we don't know.
So you do want to generalize it, but it's to the UK population or to
the UK population
rather than international. Okay, thank you.
And also with ankle replacements, the use of ankle replacements has changed completely over the last decade. So now the mobility was the leader when the NJR first started publishing data, and now the Infinity is used most commonly. So a lot of the data is on prostheses that aren't still implanted.
Okay, thank you. And just to understand the data that you've requested, so you've requested NJR data for multiple countries, but it looks like you think the HES linkage is an essential component of this to pick up some of the outcomes that might not be captured on A2 forms. But
yes.
HES data is only available for England. So is this just English data that you're after?
Yeah, so it is just English data that I'm after, and it's the data linkage, and that's vital to get the outcomes for the NHS Digital, because if we don't link the data, if we know that people aren't very good at filling in A2 forms if they're converted to an arthrodesis, so only by linking it with NHS Digital data will we have a better idea. And as we know, it's not perfect solution because we know NHS Digital data isn't complete, but it will give us more of an overview than we have at the present.
Completely. And one thing to look for is those that are performed in the private sector. Because if it's privately funded, performed in the private sector, that doesn't generate a HES record. So you might not have HES records for some of the people recorded in NJR as having had an ankle replacement done.
No, so there's that issue as well. We know that most of the revisions or arthrodesis would, on the whole, be carried out in NHS hospitals with being larger procedures. But again, this is to get a better outline. It's not to give a definitive answer, but it's to give more of an idea than we have at the present.
Okay, thank you, Toby. That was it for me.
Mike Reed, I think you had some queries also.
Yeah, afternoon, Toby.
Good afternoon.
Mine's just a very, very straightforward question. So you've said you want to exclude incidental replacement of a mobile bearing implant. Do you want to talk us through what that is and why you want to exclude it?
So this is one of those debates that people have about what is a true failure of an ankle replacement, which is different from other joint arthroplasties. So at the moment, most papers are not saying if the polyethylene is changed, that's not classed as a revision according to most papers. Whether you agree with that or not is up for debate, but that's the definition that's used in most of the papers that are published. This is less of a case with a more modern prosthesis where then fixed bearings. A lot of the earlier prosthesis were mobile bearings, so many underwent just an exchange of the polyethylene.
So are you saying then that simply isn't a revision? I mean, I'd be interested to know what our patient representatives think about that.
So one of the things I'm going to look at both ways is looking at it with it taken out, with polyethylene exchange in the total number or without the total number, because that's you speak to different foot and ankle surgeons, they look at it in different ways. So I'm going to be looking at it, including both figures to give a full representation.
Okay. All right. Thanks, Toby.
Andy Judge now is going to ask some more statistically and design and analysis orientated queries.
Hey, Toby. It's mainly around your sample size calculation. So the way you've done it so far in the application is more about model overfitting and numbers of degrees of freedom you'll have in order to get event rates at the end. But I think trying to ask, what sort of clinically important differences in vision rates are you trying to look for here? And I guess my second question would be, when you do link in the HES data and look at revision reoperation, your event rate must be much higher. And so how will that also affect your sample size here?
So the first question, what's a minimally clinically important difference? Because we're looking at survivorship, it's difficult to say exactly what it is. But that would be judged. It's difficult to say exactly what you judge as a minimally clinically important difference. But if something's a few % higher failure rate at a couple of years, obviously that's something to look at. And it's difficult to say whether 10 more revisions is significant or not. We're talking about smaller numbers than hips and knees. So a 10 rate, just 10 more revisions could add an extra % onto the failure rate. So a couple of percentage may not be different, but that's one of the reasons for doing the survivorship with a 95% confidence intervals, to find out the range of what it may be. And especially when just looking at the survivorship of different implants, that will be quite interesting to see, because it's with the small numbers, it's very easy to get what looks like large differences, but it not actually be a statistical difference. And then the second question, looking at complications and reoperations, that will be just generally looking at that. And again, it's difficult to say. In ankle replacements, there's a classification looking at specific complications. So that will be, they're graded into low, medium, high. So it will be looking at those different levels of complications based on the reoperations.
Okay, thank you.
We have two lay representatives on our research committee panel, Robin and Gillian. Robin, you have some questions, I think, perhaps?
Yep, thank you, Mark. Hello, Toby.
Hello.
I like this application to make the work engaging and a benefit for patients. I'm interested how this work is going to be translated for you in practice with the surgeons and patients. So how do you think or expect the results from this work to be presented, particularly for the patient perspective? So in the application, it mentions further information from the work would be given to patients in the consenting process. So do they get to see anything in a visual form, or will it be conversations, do you think, relating to the outcomes from the work? Will it be sort of verbally driven by the surgeon? That's if the surgeon does actually mention this. I'm just thinking from the patient perspective that it's available and it's easily understandable, and it's something that is tangible for the patient to get to see.
Completely. So there's a few things that are important for the patient here. The first thing is, what are the failure rates? Are they actually higher than we think? And are there risk factors for failure? So are there some patients that we shouldn't be performing ankle replacements in that we are now? So just by getting that information, that will give us more information and be able to improve patient outcomes by making sure we provide the right operation. Because with ankle arthritis, it's not just an ankle replacement. You can do this with fusion, which we know works well. So if it's obvious that some are failing earlier, we can then think about that will come out from the data, and then maybe those patients should be undergoing a fusion. Also, I say the consenting process, because at the moment we say the failure rates are what they are based on the National Joint Registry and what's that is at the moment. And that one of the reasons for doing is that we think those failure rates are lower than we suspect. So the information will be given to BOFAS, it will be presented to its members. So therefore the people undertaking ankle replacements will be able to relay this to patients and what the survivorship and the failure rates are for the ankle replacements that they perform.
And do you think it should be more like a verbal conversation, or do you think something should be presented to the patient in, say, more a visual, like a graphical form?
So there's already the NJR patient information leaflets that we have for that, and I think in a graphical form that would be useful when we have it. But I think one of the things when you're consenting a patient, you have to give them what the rate of failures is. That's what what I would expect to tell a patient, that we expect this many to survive. So I think it's important that that's told in a conversation as well. Because with ankle arthritis, it is very much a discussion between fusion and replacement, and the patients need to be given the correct facts of the benefit.
Okay, and just very quickly, if you were looking, say, longer term, there already exists the patient decision support tool for joint replacement surgery. Mark here was involved in. So with your work here, it's involved using modelling, using, say, demographic information with age, sex, and so on. Do you think there's the opportunity at some point in the future to take this work further and to use as a more interactive tool to aid that surgeon-patient conversation?
Yes, definitely, because it's very much, it's a complex area, ankle arthritis. So I think this does need to be taken forward and to aid patient decision making, because, like I said, it's not a straightforward decision in ankle arthritis, and you've got to consider lots of other facts such as the subtalar joint and other things around, other joints around there. So it's really important we have an idea the ones that are failing and then can have that discussion.
Great, that's super. Thanks, Toby.
Jill.
Hello, Toby.
Hello.
I'm the other patient representative on the research subcommittee. I very much liked your application, and maybe compared to all the others here, I have a particular interest because I have experienced a very complete arthrodesis in the last 3 years, having had my first partial one in just before 2000. I share all Robin's concerns, and you've answered them well. I would be keen, as I encourage all applicants, that perhaps you sharpen up your communications on the lay summary, which was in the DARF. It was kind of just a rewrite of the section on what is the proposed public benefit of this research work. I think all the things you've mentioned to Robin could also be brought into any kind of lay summary about the outcomes that patients might expect from your research.
Yes. So yes, that's something I can definitely do. Go away from this to improve that writing. That's not a problem.
Okay, thank you very much, Toby, for joining us today and telling us all about your exciting research project. What will happen now is that the committee will discuss further your project, and we will write back to you within 10 working days on the outcome of the application. So thanks again for joining us.
Sorry, Mark. Can I just ask Toby a further question?
Yes, of course.
Just about your patient involvement and engagement, your PPIE. I didn't see anything in the application. Did you have any plans for that?
Yeah, so I did have discussions with patients who underwent fusion and arthrodesis to discuss, did they get enough information, did they understand about it? So it was discussed with patients about what they would want to know informally before that application. So that was undertaken as an informal process.
Yeah, and bear in mind also that something like ankle surgery is one of the lesser known. So do think about the dissemination area, where you've got an opportunity to engage further with the wider audience, wider stakeholders, and particularly the public.
Yes, certainly. Thank you.
Okay, thanks.
Right. Nice to see you, Toby, and we'll be in touch.
Thank you very much.
Okay, panel. So I think we've identified a few areas here that where we think the application could be further strengthened, and these include clarifying the research definition, which regions of the UK are actually going to be data are going to be gathered from for this, an outline of the some of the aspects of the procedures and definitions, power calculation, tidying up and understanding clearly what the effect sizes are that we're looking for that are not present in the current application, what is going to be done about patient engagement, and in particular around not necessarily the inputs but the outputs, how we present that data to patients, how it might be developed in the future for an application of the patient benefit, and also the lay summary was felt to be perhaps a rehash of what was there in the existing scientific elements, and so there's an opportunity there. And so what we normally do at this stage is categorize the applications into 3 outcomes, the top being accept as is, the middle one being accept in principle, subject to track changes, edits for chair's approval, and the third being to reject and resubmit. And so we'll now, based on the application and on the responses we've received thus far, we're going to have a show of hands for each of these positions. So firstly, accept as is. Okay, our next category is accept in principle, subject to revisions which the applicant will submit in writing for chair's approval and any further action required. Show of hands for that, please. Okay, so that's the majority, and just for the sake of completeness, any on the reject and resubmit in its entirety. Okay, thank you very much, panel. So that illustrates what happens in a normal research committee meeting where we have an applicant coming to discuss their project with us. I hope you found that interesting as an exercise for the webinar. Thank you for your time this afternoon. And thank you again to Toby Jennison for very kindly sharing his research application with us for that mock interview. We're going to move straight on now into the first of the 3 thematic sessions, the first one being survival analysis, which is going to be presented by Mike Whitehouse and Adrian Sayers.
My name is Michael Whitehouse, and I'm here with my colleague Adrian Sayers today to talk to you about survival analysis of registry data. We have 10 minutes, so this is Survival Analysis 101. We're both members of the NJR Lot 2 Statistics team, which is made up of University of Bristol and Oxford. So the main hurdle we have is that events happen in continuous time. So we have long periods of observation with events in terms of primary joint replacement procedures, for example, happening over that period of time. And implants will fail and get revised throughout the days and years that follow, and patients will also die throughout the days and years that follow. The traditional fixed sampling framework we use in study designs isn't therefore very helpful in this context, because we want to make maximum use of the data that we have available in the observations, but we want to be able to present those in a meaningful way so that they can be interpreted. So the events that we're typically looking at are of implant failure and mortality. And we have censoring that occurs, censoring both on the left side and on the right hand side. And this censoring can be non-informative or informative. And there's certain differences between the two that we need to be aware of. Right-sided censoring is the thing that we really need to think about when we're thinking about the maximum follow-up available and events that might stop you from observing an event of interest. And the typical estimation methods that we use are life tables or actuarial analysis, Kaplan-Meier methods, and competing risk models, and we'll go into those in more detail. So then when we're thinking about the implant failure rate, all implants will fail eventually, and if we could observe every implant forever in an immortal cohort, we would have the true implant failure rate, so a combination of observed failures and unobserved failures. The observed implant failure rate is what we see with the revision rate, as in some people will die before the implant fails, and those people won't go on to be revised, but the implant may still have failed. And everyone will die eventually. And it's important to know the approximate mortality rates in the cohorts that you're interested in. So, for example, in the National Joint Registry, on average, 30% of people will die within 10 years of a primary total hip replacement. When we have net failure, this is the estimate of the true implant failure rate. So what would happen if we had unending observations and we could observe each implant until it failed? And this is what's provided by the Kaplan-Meier estimator. Crude failure is the observed revision rate. So when we're recording data on revisions and linking them back to primaries, this is what we have. And this is a cumulative incidence function that's analogous to a what you see is what you get approach. So if we think about the events, so here we have, for simplification of display, we have 10 patients plotted. All these patients have their time set to 0 at the point that they have those primary procedures done, even though those may have been on different days. And this is the period of time that will go until the failure of the primary implant occurs. We then have mortality events. So for each of these patients, we have a period of time that these patients will be alive after the primary procedure was performed until they die. And when we combine these, this is what we get. So to take the example of patient 10, they have their primary procedure performed, and there's a period represented by the solid blue line where they have an observed primary at risk. Then the implant fails, they undergo a revision, and then the dotted blue line is the observed revision at risk period until they die. Patient 9, however, had their primary procedure performed and then died. So they have the solid blue line, which is the observed primary at risk, and the dashed red line is actually an unobserved primary at risk. So that implant would have still been in and not failed if the patient hadn't died, and therefore would have been at risk of revision. So when we think about events and censoring events, events are the primary things of interest, and you have to define the analysis that you're performing. So implant failure or revision surgery is what we do within our revision analyses, and patient death within our mortality analyses. And censoring events are things that stop you seeing the events of interest. So that could be you don't observe an event because you had your primary procedure performed in England and you moved to Australia, and therefore it's not captured within our routine data capture. Another censoring event is death. So for revision analyses, death then stops you observing a failure event that may have occurred after that time. Don't forget, a censoring event may be an event of interest in another analysis of the same data. So death becomes the event of interest in a mortality analysis rather than a censoring event. Left censoring, this is analogous to our inclusion criteria. So these are things that stop you being included in the analysis in the first place and should be straightforwardly described so people can understand the cohort that the analysis applies to. Right censoring is things that stop you seeing the event of interest. And administrative censoring is a line in the sand which dictates the assessment time, and you'll commonly see us say that we included primaries up to a certain date. Non-informative censoring. So in this context, the reason that you weren't included in the analysis is unrelated to the event of interest. So these are things we're less worried about. But informative censoring, in this case, the reason you weren't included in the analysis is causally related to the event of interest, and this is where we need to be slightly careful. I'll now hand over to Adrian, who's going to take us through the rest of the talk. Thank you.
Thank you, Michael. If you're interested in learning more about survival methods, we have an MSc in Bristol, and we'll teach you in much greater depth about these methods. But briefly, we can talk about life tables. This is probably the simplest form of method of describing the survival data. It's often used when the precise timing of the event or the censoring events are not known, often found in the population level statistics, and can be used to mask exact failure times. Historically, this is more common because the maths is a little bit easier, and data can be presented either in a graphical or a tabular format. The more common method that you'll see in orthopedic research is the Kaplan-Meier method. Now, it's not specifically developed for cancer studies or medicine, and it was developed as a pragmatic solution. So the most common descriptive method of analysis for implant performance, it estimates net failure. Has a few assumptions underlying it, which is non-informative censoring. It has this other assumption, which is the survival probability is the same for the censored and uncensored patients, and it estimates failure for what is an immortal cohort, i.e. if no one had died. So this is just a quick extract from the original Kaplan-Meier 1958 paper, just to give you a flavour of actually what the correct interpretations and why this was designed. And it's all about vacuum tubes and studying how long a vacuum tube will last. So I'll just read this last extract, which says, similarly, observations of the life of a vacuum tube may be ended by the breakage of the tube or a need to use the test facilities for other purposes. In both examples, incomplete observations may result from a need to get out a report within a reasonable time. So it's very clearly, this is a pragmatic solution to describing survival data. And all we really have to do is replace the words vacuum tube with implant and test facility for patient to actually get this Kaplan-Meier solution to fit our examples nicely. Another method of analysis is the competing risk methods, and this is a estimates crude failure, and I like to call this a what you see is what you get estimator. It's developed for when one procedure or event precludes the possibility of another event occurring, and it's widely advocated in alpha class literature due to a perceived bias in comparison to Kaplan-Meier methods. The utility of a competing risk is often misrepresented and misinterpreted as well. So should be very careful when you see these methods about how you interpret them. So to give you a simple example, so this is taken from one of our papers, which I'll give you the reference for later. And what we see here, we've created a very artificial scenario where you have 10 years worth of follow-up data where everybody fails within that 10 years. And that's the blue line. Everybody's immortal and their implants fail. So it goes from no failures down to everyone fails at 10 years. And it's evenly distributed, so that's why it's a diagonal line. Now, if we generate a mortality profile, as Mike described earlier, and we overlay that the failure profile, we get some censoring. So we do the Kaplan-Meier method again, and we use the non-informative censoring, the two random processes, and we can see that the red line overlays the blue line, i.e. it's estimating what we really wanted to estimate, i.e. implant failure. If we use the competing risk methods, we can see actually that the green line really curves off and it ends up at 50% at the end of 10 years, i.e. that half of the people died before their implant failed, and so this is what you get. It's kind of expected. So the question is what to use and when. Well, if you were a surgeon and you wanted to know what the true implant failure rate was, either in the short term or long term, but you were concerned that the mortality in the long term will bias the results, what method should you use? Well, the answer is Kaplan-Meier. So the second scenario is you're a surgeon and you want to communicate with your patient the likely chance of experiencing a revision, accepting they may die before the implant fails. Well, this again is the cumulative instance function. If you were a healthcare provider and you wanted to know how many revision surgeries your hospital should plan for, what should you use? Again, the cumulative instance function. However, if you were a regulator and you wanted to know if implant A was better than implant B, or vice versa, what should you use? Well, the answer is Kaplan-Meier. So if you want to learn more about the competing risk methods and the Kaplan-Meier methods and when to use them, we have a paper in Active Orthopedica, which is open access. If you're interested in the statistical literature, there's a few other papers from Gooley, which has been cited thousands of times, and the one by Heinz Putter looking at competing risks in multi-state models. So this road has been well trodden. We are not the first to go down this in orthopedics. They have been looking at this in heart surgery and heart valves for quite some time. There are other methods you should be aware of as well. So these are regression-based methods, and the typical ones are Cox proportional hazards model, and this is analogous to the Kaplan-Meier approach, and it also relies on hazards being proportional over time. There are other parametric or regression-based methods for net failure, such as the Weibull model. This has another couple of key assumptions, i.e. it assumes monotonic hazards. The hazards may be either modelled as a accelerated failure time or a hazard-based interpretation. There are flexible parametric survival models as well, which can be formulated as either a Kaplan-Meier approach or a competing risks approach. You don't have to rely on proportional hazards in all instances, and you can make predictions. There is also something called a fine and grey approach, which is a competing risk approach. It's very difficult to interpret, and it's probably overused in this context. And you should really be careful when you see things like sub-hazard or sub-distribution hazard. So that's the end. It's a very quick tour of survival analysis. And if, as I said, if you need to learn more, there are short courses in Bristol, and we do a full MSc where you'll get to grips with these things much more easily. Thank you.
Thanks, Mike and Adrian. Next is modelling and prediction. In this thematic section, we'll be dealing with modelling and prediction. I'm Mark Wilkinson, Chair of the Research Committee for the NJR, and I'll be talking about what modelling is and why we may wish to perform modelling activities. And then Andy Judge, who's analysis lead for the research committee, will talk about specific applications of modelling and their strengths and limitations. So first of all, what is modelling? Well, here we aim to create a mathematical or visual representation of a data set so that we can describe connections between the data points to enable us to predict a given output for a given set of input variables. And this is an increasingly powerful tool in our modern big data era. So why might we want to make models in healthcare? Well, our models aim to study the system performance to provide better patient outcomes, greater safety, and also lower costs. So in the healthcare planning scenario, we may want to do modeling so that we can understand optimal budget and resource allocation, and also manpower planning, and what infrastructure we might need to deliver the optimal healthcare outcomes. From a surgeon perspective, we may be interested in patient characteristics that lead to specific types of outcomes. What are the optimal choices, for example, of implant and surgical approach that we may want to achieve those outcomes, and also understanding around the perioperative environment that may impact upon outcomes. And from a patient perspective, it's really about informing the most appropriate choice amongst the various options that are available, so that patients fully understand what the risks and benefits are of what of their planned choice of healthcare intervention. So here's a clear example of using modelling to predict outcomes. It's the patient decision support tool from the NJR, and you can see it here. You can access it easily on the internet through this website. This model uses a flexible parametric modelling approach to predict given outcomes for a particular set of patient, surgeon, and surgical environment input variables. So if we just look through the example here, we can see here are the patient characteristics that are used in this model. And then also there are, as you work through the model, there are also variables on the patient-reported outcomes, pre-op proms, and prediction for post-op various outcomes. And then if we go to the outputs, you can see here we've got a risk of repeat surgery over 10 years using the flexible parametric model, given a patient set of input variables, risk of death over 1 year, and also the pre-op prom and the estimated post-op prom. And this is based on a data set of nearly 3 million patient episodes recorded within the NJR. So if we look now at the modeling process itself, the first part of the modeling process is asking the question, and we need to be careful that we select appropriate modeling approaches that fit that question. So we shouldn't over plan the model in terms of variables. We need the variables that will predict the outcome. We then formulate a mathematical model and test it against the data. And if we find that the model doesn't fit, we then go through that process again until we optimize the model. And then we go through a validation step, which ideally is using either a subsets of the original data or a completely independent data set to answer our question. So what then makes a good model? Well, the key point really is that we ask the correct or the right question. And then the design fits the question, and we have the appropriate data, content, and structure to answer that. Our models may take a variety of formats. They may be hierarchical, so A leads to B leads to C. It may be a relational model between A, B, and C, or a broader network. And there are other examples of model structures. We may be asking a classification question. So we want to make A discrete to B. We might want to see the relationship with B upon A in a regression type model, or we may be looking for clustering of particular characteristics, say within a geographical or within a temporal framework. There are a variety of different model types that we might use. These may be traditional statistical models or alternative model structures. They may be linear in their design or non-linear as well. Clearly, it's important the number and type of input variables that we have. for a given output. For example, we want to have, a relationship of at least 10 outcomes per input variable per number of input variables that we use. And lastly, we want to be clear about what the characteristics are of the output. For example, is it events per 100 person years? Is it events over for a given period of time or number of individuals? And lastly, we need to be very aware of the model strength and its limitations so that we make the appropriate interpretations from the data set. For example, we need to know clearly what the data source is and how complete it is, what the data quality is, what pre-processing has already the data's already been through, so that we understand what the biases are, what the balance is between the cases and the controls within that series, and how well they are matched, because this will all influence the interpretation. And we need to be clear about how well, we need to be aware of model fit and model overfitting, and that we have appropriate validation methodologies, or we use appropriate methods for the validation. And there are a variety of different tools that we may use for that, to do that. Okay, so now I'm going to hand over to Andy Judge, who's going to talk more specifically about particular types of models, their applications and limitations. Thank you.
Hi, my name is Andy Judge. I'm now going to give a brief overview about prediction modelling. So predictive or prognostic modelling is different epidemiological studies that have a specific hypothesis or research question to be addressed. Here, we're not looking at whether some specific exposure, for example, drug A versus B, or general versus spinal anesthesia, or universes towards knee replacement, is associated with some outcome of interest, nor are we interested in whether or not there's a causal association. Confounding is also of no relevance in a predictive modelling study. Instead, we are trying to identify a wide range of factors that can help explain whether or not a patient is at higher risk of the outcome of interest. Clinical and biological plausibility is also of limited relevance, as all we are trying to do is identify someone at higher risk, and if a proxy or intermediate factor can explain that, then that is helpful. So predictive modelling is a form of analytic epidemiology. There are a wide range of potential risk factors. These could be patient demographics, lifestyle factors, environmental, genetic, and so on. Within the NJR dataset, there's actually a small and limited set of potential risk factors that have been measured and collected in that data, and it's specific to the joint replacement procedure, with the majority of the details around the implant and procedure itself. This can be widened through data linkers, such as to hospital admissions data, or if you can get necessary permissions, other datasets from primary care or biobanks. In terms of background readings of how to conduct a predictive modelling study, I would suggest reading through these short position papers by Doug Altman and Gary Collins, published in BMJ Research Methods and Reporting. There are more up-to-date papers since then, for example, the Prognosis Research Strategy Progress Statements. There's also the Transparent Reporting of Multivariate Prediction Models for individual prognosis or diagnosis, which is TRIPOD. There's also the TRIPOD statements worth looking at. So the statistical methods that you would use to develop a predictive model are the same as for any other epidemiological study, and these are covered in my other talk. You'll be using regression modelling, with the type of regression modelling defined by the outcome you're interested in. If you have a time to event outcome, such as time to revision surgery, it'll be survival analysis, such as Cox regression or flexible parametric survival models. For binary outcomes, it'll be logistic regression, and continuous outcomes, linear regression. One consideration is if you are considering predictive modelling study using continuous patient-reported outcomes, like the Oxford Knee Score, is there are many ways to define this outcome, particularly with repeated measures before and after surgery. I would note that as knee replacement is highly successful, and the majority of patients have substantial improvements in pain and function, if you look at the change score, which is the third picture on the right, if you analyse this as a continuous outcome, you're trying to differentiate between people with an excellent outcome versus a really good outcome, and that's not relevant clinically. What we are more interested in is those who do not get clinically meaningful improvements or who do worse. So it may be better to have a binary outcome, identify those at risk of being in the tail of the distribution, those who do worse. There are a number of things to consider when developing a predictive model. Firstly, you need to acknowledge that predictive models always perform better in a dataset they're developed in, and you can get poor performance in a new dataset of patients, which can arise from differences in healthcare systems, massive set measurements, and other patient characteristics. So we always need to have a model validation. This could be internal validation, where you could develop the model on a random sample of patients and validate in the remainder, or you could do it temporally on early versus later years of more recent data, or you can use resampling methods such as bootstrapping or cross-fold validation. What this does is by doing internal validation, you get an estimation of bias corrected, measures of model performance, and ultimately you want a proper external validation sample. To select variables to include in the final model, we should always use backward selection with the AIC information criterion if possible, and do not exclude variables that are not significant neurovariable analysis. If a possible predictor variable has a lot of missing data, you should consider excluding it, as this will occur when you try to apply that model in clinical practice. You must also publish the final model regression equations so others can then use your model, and that includes the constant term. Performance of the predictive models needs to be tested in respect to calibration and discrimination. Calibration is how well predictive risk agrees with observed risk. You do this across all deciles of patients from low to high risk categories. And discrimination is about how good the model is at explaining variation in outcome, and is assessed using different measures according to the type of outcome variable. So this is an example from the QRIS2 cardiovascular risk prediction score. It was developed in the Q Research primary care database, and this is from the external validation study using the thin primary care data. You can see they've tested model performance across different age and gender groups, comparing discriminatory performance to the previous QRIS1 score and the Framingham score. And the area under the curve or C statistics, when you look at them, are all quite high, showing good discriminatory ability, where 0.5 would be no discrimination and 1 perfect discrimination. If you look at the calibration plots on the right for deciles of predicted risk against observed risk, there is some evidence it does not perform well for the highest risk groups, and that's particularly for the Framingham risk score, where the points move away from the line of the model underestimating the cardiovascular disease risk. And I'll finish there. Thank you.
Lastly, we'll have linked data sets in this series.
This is a presentation about linked data sets. My name is Amal Rangan. I'm a surgeon member of the NJR Steering Committee. I'll be sharing this presentation with Richard Armstrong, who's actually head of health registries at NEC Software Solutions. I'll provide the context and an introduction to data linkage, and Richard will cover the more practical aspects of how that's actually done. To start with, what is data linkage? It's just a method of bringing together information from different sources about the same person, and that creates a new and richer data set. In order to do that, you'd have to have a really clearly defined purpose of why you want to link data, and be realistic about the availability of data across the data sets. And a unique identifier is important in order to be able to identify that person across the different databases in order to bring their data together. The NHS number, for example, is used by the NJR and by a number of other data sets in order to facilitate that. So NJR routinely performs external data linkage for various purposes. For example, prompts for hips and knees are collected remotely, and so by other means, and so that has to be linked with the NJR dataset in order to determine clinical performance and patient outcomes following joint replacements. Mortality is another outcome that the NJR reports, and for that linkage with the ONS helps. In order to look at the compliance in terms of the completeness of NJR data submission, linkage with HES and the Welsh PEDW database actually helps. It is possible to link with other data as well. For example, the CPRD, which is the primary care database, or with other registries. In order to do that, it's important to have a good quality study design with appropriate methods within the study protocol. And we actually look for that when applications are made to the research committee. We look for the breadth and the relevant expertise within the team, and in particular, having a statistician who helps with methodology and analysis aspects of the data is crucial. So the advantage of having larger data sets is it enhances the scale and inclusivity, and it also broadens the questions that you could ask and the questions that could be answered. In many ways, although these data sets do help answer some of the questions, they are particularly important in identifying important research questions that only other types of studies can answer. For example, why are 20% of patients who have knee replacements dissatisfied? And that is hypothesis generating. And that actually came out of this particular paper, which was published by Paul Baker and Simon Jameson, who were the very first two NJR fellows. And they identified that by linking PROMs with NJR dataset, that a proportion of patients who had knee replacements seem to remain dissatisfied. The drawback of linking large data sets is essentially the suboptimal or incomplete linkage in terms of data being incomplete or the linkage not being complete. And that reduces the utility of such a database. And this is where having a good knowledge of the data fields available within the various data sets and being realistic about the what is achievable in terms of completeness of linkage will actually help. Now, there are two types of data that are released from the NJR. There's the fully anonymized data and the linked data, which is a pseudonymized one, and that's the one which requires a unique ID in order to be able to link these data sets. In order to go through the practical aspects of it, there's quite a bit to consider, and Richard will cover those practical aspects of it in the rest of this presentation. So thank you.
Thank you, Emma. And hello, everybody. I'm Richard Armstrong from NEC Software Solutions organisation, formerly known as Northgate. And we are the contractor for the data collection and data reporting aspects of the National Joint Registry. And following on from Amar's talk, I'm going to talk a little bit more about the types of data that we link to within the NJR. I'm going to talk about how we undertake the data linkage, and then I'll just finish on a bit about how you access the linked data. This diagram here gives a view around the process from data coming into the NJR all the way through to the data extracts that we produce. So on the left, we have hospitals submitting data on a daily basis into the NJR data entry system. On a nightly basis, that data is extracted and copied into our NJR reporting data warehouse. And it's from that data warehouse that typically we would produce data extracts, and a lot of the reports that come out of the NJR routinely come out of that data warehouse system. And it's at those 2 points, at the point of the data entry system and at the point of the data warehouse, that we typically do our linkage to third-party data sets. And typically the linkage that we do on the data entry system is around validating and improving the quality of the submitted data. That includes things like looking up the GMC code for surgeons, looking up the organisation code for hospitals, and checking the demographic information of patients. And the linkage that we do on the data warehouse is typically more around enriching the data that sits within the warehouse, giving us additional data points, additional outcome measures. A good example of that would be linking to PROMs data and giving us PROMs as an additional outcome measure that's not routinely captured within the NJR. So we'll dig in a bit more detail and look at an example of the type of linkage we do within the data entry system, which I've said is around improving the quality of the data typically. So we have access to the National Back Office Tracing Service that allows us to validate patient demographic information that we have within the NJR. And it also allows us to fill in some of the gaps of information that we might not have within the NJR. So we'll routinely send a file of patient identifiers from the NJR off to the tracing service, and what we'll get back from that is a validated NHS number. Maybe that we didn't have the NHS number and it gives us the NHS number, or maybe we have the wrong NHS number, or it just confirms that we have the correct one. The address for the patient, the most recent address for the patient, and that's important because within the NJR we will do ongoing PROMS follow-up for some patients, so it's really important we've got their most current postal address. And it also gives us the mortality status of the patient. So when we do our outcomes reporting and analysis for mortality, we have the most recent and up-to-date mortality status for patients. So this is a really important process that we routinely go through in the NJR to improve and validate the data that we have within the registry. An example of linkage that we do within the data warehouse is our linkage to the HES and PROMS data set. And this is just as an example, but typifies the process that we go through to link NJR. So we have our NJR database and we have a third-party database, in this case, HES and PROMS. And we have to identify data items that are common across those two databases to be able to determine a record in the NJR that correlates to a record in the third-party dataset, in this case, HES and PROMS. And the data items that we're using here are the NHS number, the patient's NHS number, and we've talked about how we validate that. We also use the local patient ID, which is the unique reference number used within the hospital to reference that patient. We use the unique provider code, the unique reference number that relates to the hospital. We use the date of operation. We use the patient's date of birth and the patient's gender. And where we find those data items match corresponding data items on the HES and PROMS database, we would say that there is a match between those records. And we would then record that in a linked data file, depicted here as the red database on the diagram, which in essence is often just a file containing the unique reference numbers for the two databases. So record 123 on the NJR corresponds to record 456 on the HES PROMS data set. So it gives us the links between the two data sets. And in the case of linking to HES and PROMS, we actually have 7 different methodologies that we apply to determine the linkage between the data sets. And a record may link on all 7 methods, in which case we'd say it's a very strong linkage, or it may only link on 1 or 2 of these methods, but we would still determine that to be a linked record, and it would be recorded as such in our linked pseudonymized data file recorded here. So for each record in the database, we would apply those 7 tests. And say in the best scenario where all record items, data items link, it would match a record based upon each of those 7 tests. But as I said, if we had missing data or anonymous sort of incorrect data, it may be that it wouldn't match on all 7, but we would still define it as a linked data record as long as it linked on at least one of those methods. So for example, we're taking the NHS number and operation date from the 2 databases, and we see them to be the same, we'd record an entry in that linked pseudonymized data file that would allow us to then do an analysis that used both NJR and HES and PROMS data for that patient. So in the case of the HES PROMS data, that's supplied annually to us from NHS Digital. Clearly, it includes patient identifiers because we use that to determine the linkage between the data sets, as I've talked about. And our HES and PROMS extract is actually only a subset of the HES data sets, because clearly from the NJR's perspective, we're only interested in joint replacement patients. So there's 450 operation codes that we've determined as being relevant for joint replacement. So it's the subset of HES that relates to those 450 codes that we're interested in doing the linkage for against the NJR. And that linkage is really important to us for the NJR because it enables us to do outputs such as surgeon, hospital and implant level PROMS analysis, for example, using data that we in the NJR don't capture, but is captured through that national HES PROMS linked data set. So being able to have a robust method to link to external data sets is important because it expands the types of analysis and reporting that we can do routinely within the NJR. So some considerations in data linkage. Important to note that we can only do linkage where we have a legal basis to do it. So that could be the consent of the patient, or it could be Section 251 support, but we can't just go off and link to any old data set without having the legal basis to do that. And for all the linkages that we do today, clearly we have that in place. It is also possible for external requester to ask for NJR to be linked to another data source, or to link to an NHSD data set, for example. To do that would need to determine what that legal basis is, and we within the NJR would be able to do additional linkages to other data sets where we had the both data controllers and again ultimately the right legal basis to do that. Another point to note here is that the NJR actually has a sub-licensing arrangement with NHSD, so it is able to provide pseudonymized linked data to a third party for the purposes of research and analysis. So if something that is required, it's possible to get that linked data through the NJR, through that sub-licensing arrangement that we have with NHSD. So we've talked a bit about where we do the linkages, and we talked a bit about how we do the linkages, and ultimately that results in extracts of NJR data, linked NJR data, so data that's come through from the hospitals and data that's then been linked to it from other third-party sources. And we have a range of data extracts containing those linked data files, and we would then typically make those available to third parties through the NJR Data Access portal, which would give somebody secure access to that the linked data sets for which they've been approved through a secure online portal mechanism. Very much a whistle-stop tour of all things NJR data linkage. Hopefully that's been helpful, and thank you for your time.
Thank you very much, all the speakers in these thematic sessions. We're going to take a short break in a moment, but just before we do that, I just would like to remind everybody that if you put your questions in the Q&A, we're going to have an extended Q&A session at the very end of the afternoon, and it would be great if we could stock up some questions for that. We're now going to take a short break until 3:40, and then we'll resume with statistical analysis plans. Welcome back, everybody, to this final session in our webinar. And now we're going to kick off with Andy Judge talking about statistical analysis plans. And just a reminder, if you have any questions, put them in the Q&A and we'll deal with them in the session, in the final Q&A.
So hi, my name is Andy Judge. My background is as a medical statistician with expertise in analysis of large routine datasets and registries such as National Registry. And the aim of this talk is to provide some help and advice on statistical analysis plans for those of you planning on submitting applications to the NJR Research Committee to access data for a research study. So this talk is separated into 3 parts. Firstly, to start by focusing on the research question, as this is the most important part of any study. And if you get this wrong, then that affects your study design and subsequent statistical analyses. We'll then look at statistical analysis plans, following that set out in the Strobe reporting guidelines, and looking at some of the data contained in the NJR and the linked data sets available for analysis. And finally, we'll cover statistical methods and highlight issues that you need to consider, such as sample size, bias, confounding, and confoundable indication. So we'll start at the beginning with the research question. So first we need to think about this FINA acronym. So feasible means number of subjects, technical expertise, time, money, and scope. So first of all, do you have enough subjects? That's about your sample size. But also thinking about loss to follow-up, getting feasibility counts if looking at specific constructs and brands, see if your study is possible. Then does your team have the skills and experience to design the study, do the data management and the data analysis? And you must have a statistician on your applications to the NJR. The scope of your study may be too big. You might have too many secondary outcomes, be collecting too much data. You need to focus on the important research question. It should be interesting. It's important not just to surgeons, but also patients and general public. And it should be novel. So you need to become masters of the literature. Chances are someone's already answered your question, but even so, could it be done better? Then your application needs to give a brief literature review, covering why this is an important question, what research has already been done with references, what new research is needed now, and the rationale for your proposed study, and then set out the specific aims and objectives of this study. For ethics, for linked data, you used to need to obtain Section 251 HRA approval, and you do require data security and protection toolkits in your institution, or nowadays you can also use the data portal. And in terms of the relevance, this is the so what bit. How does this change clinical practice or influence policy? And how does it advance our scientific knowledge? All things you need to think about. You should always define your research question using the PCOS format. And this needs to be very specific. So in terms of population, what is the population you want to study? Is it all of the NJR, specific implants, only younger patients, specific hospitals? You need to specify clearly what your inclusion and exclusion criteria is, including dates for study start and end and length of follow-up. For intervention comparator, this is your exposure variable. It could be cemented versus uncemented, old versus young, obese or non-obese. You need to define exactly what your exposure of interest is, or for a prediction study, list all the relevant predictors or risk factors you're interested in. And what is really important is you must have a control comparator group. Just looking at the outcomes of your favorite implant in a case series study is of no interest or relevance. The most important bit is the outcome, and usually in the NJR this will be revision, but define if it is all cause revision or cause specific, at what time point, such as 10 years, that all your exposure groups have the same time at risk and potential follow-up, and you need to decide what is a clinically meaningful difference between exposure groups in which to power your study for the sample size for this particular outcome. And consider potential for measurement error in the outcome, particularly using revision as the outcome. For other outcomes like PROMs, reoperations, complications, you would need linked data. So we now focus on what you need to cover in the methodology section of the NJR application. So the easiest way to structure the methodology section is to actually follow the Strobe reporting guidelines that are displayed here. So I would start with your data sources. So is it NJR only data, or will you be linking to hospital episode statistics or patient-reported outcomes data? What is your inclusion exclusion criteria? Define your outcome variables. What are the primary and secondary outcomes, being specific, how they are measured, and at what time points duration of follow-up? What are your predictor and exposure variables? And all of this should have already been thought about and defined when refining your research question. As this is an observational study design and not a trial, you do need to think about confounding variables. So this is thinking a priori about all other potential factors that are causally associated with the outcome of interest, that when you adjust for, could explain your association you observe between your exposure and outcome. But you can only include what is measured and collected in a data set though for confounders. It's also really important, so you need to specify exactly what variables and data you want from the NJR when you put in your DARF application, as that's what you'll get given for your study. If you want additional variables, you have to reapply for that data. Sample size is very important. You need to include a sample size calculation. There are patient and public involved members on the research committee, and so we will be expecting a PPI section in your application on how patients have been involved in the design of your study and to refine your research questions. And you need to think about potential sources of bias, as you want to address this through study design a priori if possible, rather than it being a limitation once you finish your study. So selection bias, measurement error, and so on, all things need to be considered. Also think about whether we're missing data, and is there enough duration of follow-up for what you're interested in. So this shows the amount of data contained in the NJR from the most recent annual report, covering primary hips, knees, ankles, elbows, and shoulder joints with linked revision operations. The data collection did start in different years for different joints, the hip and knee joints having the largest numbers and longest follow-up. But it is important to note that data completeness for these joints became much better after 2011, where the Department of Health made NJR compliance mandatory on the 1st of April 2011. And you need to decide which joints and user data you want to include in your analysis. So to understand what data is contained in the NJR, a good starting point is to look online at the data collection forms, where this is the form for primary hips. And note this is version 7 of the NJR dataset, and some of the variables and data collected does change over time. Likewise, there are forms for the other joints, and you can view all these online to look at what data is available. If you are using only NJR data that uses no patient, surgeon, or unit identifiable data, and no linked data such as HES or PROMs, this would be classed as an independent external NJR supported study. In all other cases, it would be an internal NJR collaborative study, and that may require personal identifiable data or use of linked data, and therefore you need to identify a collaborator from the NJR Research Committee to work with. Data linkages can be obtained, such as hospital episode statistics and patient-reported outcome measures. This would usually require an application to NHS Digital and Health Research Authority for necessary approvals to access such data. Maybe a cost involved. However, recently the NJR Data Access portal has been created to provide researchers and others requiring data access to work with the latest NJR Research Fellow dataset for a self-contained environment, and that's a new option. So this shows some of the data available within the NJR, with underlying variables being obtained through data linkage. You can see there are patient case mix factors, surgical information such as surgical approach, prophylaxis, indications for surgery, implant types, and so on. The main strength of the NJR data itself is the ability to look at detailed implant constructs, but deriving such information is complex and difficult to do. The main outcome within the NJR is revision surgery, and whilst this is complete, objective, and linked to all primary procedures, you do need to consider the issue of measurement error in such an outcome variable. An operation is only defined as having failed if it is revised, so patients with a poor outcome have not been offered revision surgery or don't get further surgery are not captured. So it's an overly optimistic representation of the success of surgery. Surgeons may perceive some implants as easier to revise, and some patient groups may be more often likely to offer revision surgery than others. Also, revision is a rare outcome and requires a large sample size, but as afforded by the registry. Now, data linkage does provide information on a wider package of outcomes, such as patient-reported pain, function, and health-related quality of life. There's also reoperations, complications, and mortality. So you need to decide what outcomes interest you. So within the methodology section of the application, you do need to include a sample size calculation. This goes back to the PICOs and your research question. It needs to be defined a priori. Feasibility counts may be necessary to see if your study is feasible, whether the event rate is high enough with a long enough duration of follow-up. Now, we don't know what the true association is in the wider population, and that's why you were conducting a research study to get the answer. But you need to estimate your sample size to minimize the possibilities of these type 1 and type 2 errors. So the power of a study is the ability to detect an association where there's actually a real association. So that's the top left box of that table. And that would normally be set at 80%. And so the opposite of this is type 2 error, that would be 20%. So 1 in 5 times, you would miss detecting the real association. And the type 1 error is significance, or the p-value, and that is usually 5%. So 1 in 20 times, you'll think there's an association, but it's just a chance finding and not real. The important thing is you need to be able to decide a priori what the clinically important difference is for your outcome of interest and power your study to be able to detect that. And therefore, you need to involve a statistician and include that in your application. So now moving on briefly to statistical analysis. So the type of data that you have informs you of the type of statistical test that you can use. This again all goes back to your research question and the outcome you're interested in and how you're collecting and measuring that data. So usually you will start with descriptive statistics. So for continuous variables, that's the mean and standard deviation if normally distributed, and the median and quartile range if the data is skewed, and the number percentages for categorical data. The above statistical tests are univariable, so they just describe the association between two variables, so your exposure and outcome, and they don't account for any potential confounding factors in your data, but ultimately the type of data you have tells you what type of statistical test you can use. So to account for confounding, you'll need to use a form of regression modeling. Again, the choice of the model is defined by the type of outcome variable that you have. So for continuous outcome variable, you use linear regression. If it's a binary outcome, logistic. If it's time to event data, Cox regression, and so on. Now, all these regression models rely on a lot of model assumptions being satisfied. So you'll need to consider this with a statistician. So for time to event data, which is most common in the NJR, the key consideration is a proportional hazards assumption. So if this is not satisfied, you may need to consider things like flexible parametric survival models or fully parametric survival models. So depending on your research questions, there are further issues that you should be thinking about a priori. See if these can be addressed through the study design and analysis rather than be limitations of your study. So this slide here is based on the Bradford Hill criteria. So first of all, the thing about chance. That's really about your sample size and power, whether you've powered your study correctly. When you have considered this and you have done a sample size calculation, and when you do your analysis, it's thinking about type 1 error, looking at the size of your p-value and the confidence interval once you've analysed your data to know if what you find is actually a chance finding or could be a real finding. Again, smaller the p-value, the stronger the evidence against null hypothesis. There's always potential for bias, particularly in the NJR. I've already spoken about bias of using revision as an outcome because there is that potential for measurement error. And this is an issue if it is differential between your exposure groups, where that measurement error is more likely, say, for one group or implant than another. There can be loss to follow-up bias, which is a form of selection bias. This is an issue for PROMS outcomes. Around 50% of data is missing at 6 months for the follow-up PROMS scores. You can also have missing data for body mass index. And the reason that becomes an issue is if you do a complete case analysis, that reduces your sample size, and you need to check if the characteristics of your sample in that reduced sample size are the same as a wider NJR population. So you can start introducing selection bias. Multiple imputation is a way to address this if the assumptions of imputation are satisfied. You need to check that. You can also have differential or different mean, median follow-up time in your exposure groups. So if, say, one implant has only been introduced recently and has little follow-up time, whereas your comparator has been around for ages, it's not a fair comparison because the time to revision, there's much more revisions more likely in one group than another just because of the time involved. And so that will introduce a bias. So these are all things you need to think about, essentially control for in your study. So confounding is where there's some third variable that could provide an alternative explanation for any association you observe between exposure and outcome. A confounder must be associated with the exposure, but not causally. For example, this is smoking and drinking. If you smoke, it doesn't cause you to drink, and vice versa, but they are associated. And a confounder must be causally associated with the outcome. So for example, smoking causes lung cancer. So if your research question was, is drinking associated with lung cancer? You would see a significant association in your crude analyses, but that would no longer be significant when you adjust for confounding regression model. But again, it goes back to your research question of why you would think, in this case, that drinking will cause lung cancer in the first place. So it always comes back to a research question. The limitation of the registry is you can only adjust for the confounders that are measured and collected. And there'll be many other important confounders, particularly things like radiography, health, behavior, and lifestyle effects, and many other unknown, unmeasured confounders. So this will always be a limitation of your study. There are ways to try and address this though, such as things like instrumental variables regression, regression discontinuity designs, propensity score matching, self-control case series, and so on. But they are more advanced methods and it all depends on your research question. I guess the point is there are more complex ways to get a more definitive answer than standard regression models. So within the registry particularly, confounded by indication is a major problem for many research studies. In a clinical trial, a person would have a 50% chance of being randomized to either the treatment group or the control group. We don't have a trial, we have observational data. So as in the above picture, There will be instances where in some patient groups, they would never be offered the intervention or they might never be offered the control. And with implants, some may only be offered to healthy, younger, fitter patients. And so, for example, if you were comparing hip resurfacing to, say, all cemented hips, you would introduce confounding by indication, as you're not comparing like with like. So in that case, there are older patient groups that will never be offered a hip resurfacing procedure. And there are other reasons like age that could explain increased mortality or revision that you've introduced by design and introduced selection bias. There are methods, things like propensity scores, that can address this, but only to some extent. And there will always be some residual confounding by indication. You need to be cautious in your interpretation. At the very least, consider matching by age and gender, or dropping patient groups that can't be matched to avoid this issue. Again, it all depends on your research question. So for some questions, it doesn't matter. For other questions, it becomes a big problem. So reverse causality should not be an issue, as the cause should precede the effect here, but you should always ensure that no patients have the outcome at the time of surgery. So this seems obvious for revision surgery, but for complications, you should be excluding patients that already have these prior to surgery, so you have a disease-free cohort at the start. And do remember, this is observational data. You can never say this is causal, and the true answer will only be known through a full clinical trial. And that's it, and thank you for your time.
Okay, thank you very much. And next, we're going to move on to ethical and governance considerations.
Hello, my name is Chris Bolton. I'm the Deputy Director of Operations for the National Joint Registry. I'm going to speak to you today about some of the key ethical and governance considerations that you'll need to bear in mind when you're designing a project and putting together an application using NJR datasets. The first thing I'm going to do is flag up the resources that HGroup developed as part of the Understanding Health Data Access program. They provide a really good beginner's guide on how one goes about applying for health data in the UK, as well as explaining one of the key concepts, the common law duty of confidentiality. All of the resources are available at the HGroup website. The applications pathway for NJR data is available on the NJR website, and it takes you through the processes that you will go through when you're applying for data. The first step is to prepare an expression of interest and submit it to the NJR. This is a high-level summary of your proposed work. NJR will assess this to see if it's feasible using NJR data and to check whether any other research groups are trying to answer the same questions in the same way. Approved DOIs are invited to submit a full application to the research committee. If projects involve sensitive or identifiable data flows or linkage to HES or national PROMS data, then the lead applicant will be required to attend the meeting to defend the project. The research committee will focus on the scientific methodology, the public benefit, and the patient involvement activities. They may also identify any critical governance concerns. If the project is approved by the research committee, then the NJR team will carry out a detailed governance review of your application and ensure you have everything you need for it to be passed to the data controller. The data controller is HQIP, and they have a data access review group that meet monthly. Once we have final data controller sign-off, NJR will construct our data management provider to prepare the relevant data files and grant you access to them. Normally, this is via the NJR Data Access portal. If your project involves any non-standard linkages or direct flows of identifiable data, you will likely need additional permissions. You'll be encouraged to try and obtain these in parallel with the NJR Research Committee review. The HQIP DARG won't review your application unless everything is fully in place. One thing that is important to do early on is to review the NJR datasets to make sure that the data you need is available. The core NJR datasets consist of data on primary and revision, hip, knee, shoulder, elbow, and ankle procedures. Within that, we have direct patient identifiers and the identity of surgeons and hospitals. These are not normally available to researchers, although we can provide pseudonymous identifiers to allow you to examine patterns. The main NJR data we can make available consists of clinical data about the patient and their treatment, and details about the implants that are used in the surgery. When you're invited to submit a full application, you'll be provided with a checklist of data items. You may only request items that are fully justified by your written analysis plan. The NJR dataset also includes the shoulder prongs program data. We're also able to provide linkages under sublicense from NHS Digital to external datasets. These include civil registration data, which provides cause and date of death, and will be required for mortality analysis and as censoring data for implant survival analysis. We can provide access to hospital episode statistics data for patients who were treated in the NHS in England, and also data from the National Hip and Knee PROMS programme. All of the datasets in blue are controlled by NHS Digital and will require you to enter into a separate agreement with us. If you prefer to arrange your own linkage permissions with NHS Digital directly, you're welcome to do so. If possible, you should discuss your project with the R&D officers at your organisation and establish whether there are any institutional ethics requirements you need to satisfy. Your application will need to show that you've considered whether your project is research. There's a useful tool on the MRC website which can help you with this if you need to. It's not necessary to try and frame your project as service evaluation if it is in fact research. If you have a research project, you also need to determine whether NHS ethics approvals are required. It's unusual for analysis of already collected de-identified data to require NHS ethics. Again, there's a useful tool at the MRC website, which you can print off and use as evidence that you've considered these questions. In order to determine what permissions are required for your project, you need to consider the type of data that you need. Personal data is data that does or could identify an individual. It would be unusual for NJR to release directly identifiable personal data to an applicant. But if your project involves the flow of identifiable data for linkages, then you need to ensure you have considered the legal basis of these flows, even if you won't have the identifiable data at the end of the process. Anonymous data is data that cannot identify an individual. For the most part, this would be data that had been aggregated to a hospital, regional, or national level. Record level data is rarely considered anonymous. Depersonalized or pseudonymous data is record level data that's been processed to reduce the likelihood of re-identification. This involves the replacement of direct identifiers with a code to which only NJR has the key. This is the most common type of data that you would get from the NJR. Depersonalized data is still treated as personal data under the law, so you still need to provide a GDPR legal basis, although there's no need to provide a common law legal basis for these, as the data is not considered confidential personal data. Talking of legal basis, there are two types of legal basis that you need to consider. The video that I mentioned earlier is really useful at explaining the difference. The GDPR legal basis is the basis for processing of personal data, including depersonalized data, under UK data protection legislation. Because we're dealing with health data, then you need to provide two parts to this legal basis, under Article 6 and Article 9 of the GDPR. There are 6 Article 6 legal basis categories. I should point out here that consent is almost never the right answer to this question when it comes to research. If you're from a university, an NHS trust, or another type of public sector body, you're likely to be able to rely on task in the public interest as a legal basis. If you're from another type of organisation, the legitimate interests is more likely to fit the bill. Article 9 is the legal basis for the special category data. That is the data about a person's health. There are 10 of these, but the ones that are most likely to be right for your projects are health and social care, public health, or archiving, research and statistics. You have to choose one, so pick the one that is closest to your project's objectives. If your project involves the flow of direct identifiers like name, date of birth, NHS number, or full postcode, you also need a legal basis under the common law duty of confidentiality. Remember, if the identifiers flow in service of your project, you need this even if you don't process the identifiers yourself. The two main types of common law legal basis you will come across are consent and approval by the Confidentiality Advisory Group. This is sometimes called Section 251. Consent would be most commonly used if you're recruiting patients directly to a trial or study and you wanted to link the study data with their NJR records. This is easily achieved by including wording on the consent form where the patient agrees to the linkage. Don't be tempted to use broad language like health records or audits and registries. If you want to link to the NJR, then say NJR. In most other circumstances where flows of identifiers are required, you will need to get permission from the CAG to process the data without consent. For research projects, this is done via IRAS. For non-research projects, there's a form you can download from the HRA website. If you need to do this, then please speak to the NJR team first, as we may be able to advise you further. This one should be quite an easy one, as it's a legal requirement for all organisations processing personal data to be on the ICO register. You need evidence that your organisation is on the Register of Data Controllers, and you can search for this easily online. Aside from the broader data protection questions, you also need to establish that your organisation has robust data security processes. For processing health data, the way that you would do this is to provide evidence that you have a standard SMET score against NHS Digital's Data Security and Protection Toolkit. You can search the register online to see if your organisation has a passing score. If you don't have a DSPT, you should speak to your information governance team locally to arrange for this to be completed. This video will be made available online so you can recap anything that I've said. But the main thing I want to stress is that you need to think about all this stuff in advance. It's a real shame when good ideas flounder because the governance implications haven't been thought through. Where possible, you should identify an individual within your own organisation, in your IG team or research governance team, to support you. And although we can provide some general advice if required, it's generally easier if this is done locally. Finally, I would say, please don't be intimidated by this. It really does look harder than it is. And if you put in the planning, then you aren't likely to have any particular issues. That's all from me today. My details are on the screen if anyone wants to contact me about anything that I've said today, or indeed about NJR research and governance more generally. Thank you very much, and goodbye.
Thanks very much, Chris. Next, we're going to have some words on the data access portal.
This is a short presentation showing you how to access and use the NJR Data Access portal. The Data Access portal is commonly known as DAP. It's a secure web-based portal that uses remote desktop, and I'll go on to explain what remote desktop means. But basically, it's a service where all your project data is stored securely on the DAP server, and all the useful applications you can use to analyze that data and write up your data is all in one place. So what is Remote Desktop? Basically, it simulates you sitting in front of the data portal, accessing the data and using the applications on that research server without actually having to be there yourself. So you use your laptop, your mouse, your keyboard, but all the data storage and applications are all stored on the remote server. And what you see on your screen is basically an image of what is being shown on the remote server. Multiple users can be accessing that server at the same time, and you won't know that anyone else is on the server either. So how do you access it? It's a URL, and you can see there it's njrdap.njrcentre.org.uk. You have a login detail to access the portal itself, and then for every project you are assigned to, you will have login details for that. So that URL takes you to the portal login. You will have a login for that portal. The front page basically allows you to see some help files, the glossary, frequently asked questions, etc., but also allows you to access your projects. So the first thing you need to do is log in. See here, your portal login is generally your email address, and you supply your password. Once you've logged into the portal, you'll see another couple of options there on the right-hand side. You'll see a project area and you will see a quarantine area. I'll explain a little bit about the quarantine area later. Okay. What I'm going to show you is what the screens look like if you're accessing the portal from Chrome. If you're using Internet Explorer or Firefox, Safari or Microsoft Edge, or even you're using a Mac, your screens will look slightly different. So just be aware that what I might show you here will be slightly different to what you might see when you're accessing your own projects. So you click on the project area and you'll come up with a second login screen, and this is your login just for a specific project. So if you are working on more than one project, you'll need to make sure that the login you are using is the one for that specific project. The username will be completely different to your portal login. Once you've logged in, you come up against a screen which shows you a number of applications and a number and Windows Explorer. This is where things get a little bit non-familiar. So you've got here 3 statistical packages. You've got Python, R, and Stata, and then 3 standard Windows applications. You've got Calculator, Microsoft Excel, Microsoft Word and Notepad. You also have a Windows Explorer. Now, each project can have multiple people working on that project, and you'll have a shared folder where your initial data is stored. You'll also have a personal folder where you can put your own workings and results for that project. Once you have logged on to your project area, you come across your project home space. This contains your applications and the storage of your research data. So you can see here your applications include a calculator, Microsoft Excel, Microsoft Word, Notepad, and then more advanced analysis packages of Python, R, and Stata. To get your actual data files, you open up Windows Explorer. And this will download an RDP file. Now, as I said earlier, this is specific to Chrome. So save that to your local drive, and you'll see it here on your taskbar. If you double click on this file, an RDP application will appear, and you'll be asked to enter your project login credentials again. Once you've done that, Windows looks to your project space. Your project space consists of the shared source, which is in this case G, shared data drive, your personal data drive for that specific project, and this is where you can record and store your results and any scripts that you have used. If I open up the shared drive, I can see that there's 2 data files in there. This data will be supplied by NEC once your project has been approved. So you can see here we've got 2 files. One's called DAP test project, which is a CSV file which we would have, NEC would have put up there for you. And then DAP test project Excel, which I have created based on the CSV data that had been supplied. You can see here, if I open up the Excel file, I've got some basic NJR data in there. It's some outcomes data, nothing sensitive, so you can see. So my project was to look at the ages of patients having a hip primary procedure and looking at the cup brands and cup manufacturers. So that's my data list. And in the results, I've done some analysis. I've looked at the age of patients having a hip primary and based that on manufacturer. So you can see here that in the data I've supplied, I was given 31,000 primaries that used a Dupuis cup, and their average age is 68. Slightly lower volume, you've got GRI Orthopedics cup brand with 1,800 procedures, and their average age was 64. So I've done all my analysis and I'm needing to extract that for publication. So I'm now back at the home screen of the project space, and I want to open up Word so I can copy some of the results to Word. So I'll double click on the Word icon and an RDP file will be downloaded, and you save that locally just as before when you opened up Windows Explorer. So go to my data file and copy the data from Excel. This is stored on the local server in the cache and not in your local laptop. So open up Word, and I can paste that data into Word document, write in some analysis notes, and save that locally to the shared drive in the project space. So you've now completed all your analysis and you've got your results ready. You now need to export that back so you can publish it. So there's one main area for downloading and uploading documents, and that's the quarantine area. So if you go to your project space on the portal, you've got a quarantine area shown above the project area here. You can upload files to quarantine space. Then NEC will check those files to ensure that the content is suitable. Once we have approved that, we will move the file from the quarantine area to your project space. Similar process is when you want to extract results from the portal. If you email Ian Mulcahy and give him the name of the file and the location of the file that you want to download, that file will be checked, and we will then be able to move that file to the quarantine area available for you to download. So I hope that's been a good overview of what's involved with using the Data Access portal. And just some contact details for you if you need. Okay, thanks very much.
Many thanks, Claire. And our last speaker in this in the formal presentations is Toby Jennison, our current NJR Fellow.
Hello, my name is Toby Jennison, and I was the NJR Research Fellow between 2019 and 2021. I'm going to talk to you today about a Research Fellow's experience of using NJR data. So, like any project, you start off with an idea. This can be that you want to use NJR data to answer a clinical question that you have. So where do you start? The task seems daunting. One of the first things you need to do is a literature review. Find out what is already in the literature, what the gaps are, and then what you want to answer. And what is that question clearly and specifically that you want to get? And how is the NJR data going to help you answer this? Once you've got your initial idea, the next thing is you need to get a team together. Depending on what level you're at, that may require a supervisor or multiple supervisors, and will almost always require a statistician for their expert input to make the plan a reality. You also need to answer the questions of how are you going to find time to do this? Is this going to be as a PhD or MD, or is this going to be as a research year, or is this going to be attempted in your own time? The first thing I can say is any idea that you have will take a lot longer in terms of years to get all the necessary approvals, and then actually analysing the data will take a lot of time and effort. Even relatively small projects will require a lot of time and commitment to get this done. That does not mean that any project isn't achievable. It just means to be realistic in what you can achieve with your current circumstances. Another early question to ask is, where are you going to get funding from this? If you're taking this as research, where are you going to get the funding to do that? Or if you need some things like data linkage with NHS Digital, how are you going to get the funding for that? And that's important to think about early, as this could be a roadblock straight away. Again, these are all things that you just have to think about at the start of the project to avoid wasting time. This doesn't mean that you should not undertake the research, as it's important, as if you think this is an important question, then it needs answering. And one of the most important things with getting through this is your own enthusiasm and determination. My project was looking at analysing the 5-year failure rates of ankle replacements using linked NJR and NHS digital data. Whilst this question sounds simple enough, to get to the project all the way through the relevant approvals took several years. When thinking of a project, it's really important you come up with clear aims and objectives so you know exactly what your primary and secondary outcomes are. The plan you're doing must be achievable, and it must have a solid statistical plan. This is one of the most important things, and therefore it's important to discuss this with a statistician and to have a clear analysis plan prior to application. The application. First of all, the approvals will depend on the project being undertaken. It should be registered with the local department and discussed with your research committee to decide what approvals will be required. These approvals range from S251 support to full ethical approval. Also, the NJR application should be completed and submitted for scientific review. This is vitally important that by this stage, there's a clear statistical plan, good background information, and clear objectives for the proposal. If the scientific committee have any questions on this, they may ask you to resubmit your proposal for a later date. A further thing to look at is the currently listed NJR projects to make sure that your idea is not replicating something that is already being undertaken. So, where do you start? You get the data once all the approvals have been completed. But most people who look at the NJR dataset will have no experience of using large datasets. So where do you start with this, and where do you get help? It can seem like a daunting task. You'll have, in my circumstance, 5,500 patients, but in many others, such as hips and knees, will have many times this. The first thing to say is it's important to have a clear plan. Data analysis will take months and months, so it's important not to find this overwhelming and have a clear plan from how you're going to go about cleaning the data and then performing statistical analysis. Depending on your circumstances, there will be many different places to get help, but the NJR have an excellent department that will help you with any questions that you have. And it's important to realise that you won't be the first person going through this process, and that other people will have gone through this before and had similar issues and asked the same questions. All the data that you receive is accessible through the NJR Data Access portal. This is an online system that you have individual access to, and individual access to your data only. This allows you to do all this analysis on an online secure platform. It is password protected, and you save your research on here. If you want to download things, it's through that quarantine area there that you ask permission to receive the downloads from it. The online version for this has many packages, including Microsoft Excel for data analysis, and then the two main statistical packages are R and Stata, depending on your preference. Data. When you get the data, there will be a large amount of data, and obviously this depends on what is requested. One of the first things to do when cleaning the data is determine which factors are actually not required for your analysis, and get rid of these early, as keeping these in will only add to confusion. It is important to format the data so it can be used for statistical analysis. And any queries when cleaning the data should be discussed with the statistician early to make sure that these are corrected so will not cause issues further down the line. Another thing that needs looking at early is how you're going to manage missing data, as there are certain fields in the NJR that have considerable numbers where the data is not recorded. Structure. It's important that you develop a clear plan on how you're going to clean the data. And one of the things is to check and double check the data and then triple check, as it's amazing how easy it is for an error to occur, which over time may have major effects on the outcomes that you produce. It's important to have a clear plan on all the data that is required for data analysis and to remove any data that's not required. And then again, it's important to have your clear statistical plan so you know exactly what the methodology is and what data is required and in what forms. Data linkage. Determining on your project, you may require linkage with NHS digital data. For example, the NJR does not have mortality data, and therefore to conduct survival analysis, linkage is required to get mortality data. The process with NHS Digital is similar to the NJR, where you must fill in paperwork and complete your statistical plan and outcomes and patient benefits for the application. You also, once all this has gone through, which can take a considerable time period, you will finally get pseudo-anonymised data. And this will therefore be able to link to your data from the National Joint Registry, depending what your outcomes are. There is also a charge for NHS digital data, depending on the amount of years and the amount of data that you require. So the statistical analysis can be done in R or Stata. You decided to use Stata. In my case, I'd had no previous experience of using this package prior to analysing the data. And therefore, a large amount of time was required to learn how to use Stata and do the necessary analysis. This was probably the most important thing that I did. All the common functionality of Stata you can get on the NJR Data Access portal and are therefore able to conduct your analysis here. Statistical analysis. So as I said, there's two packages, Stata and R. It's vital that you learn how to use the package and how to write codes and statistical analysis plans. The most vital thing I would recommend for anybody is to make sure that you use a do file. There's nothing more frustrating than carrying out a statistical analysis and then a week later realizing you didn't save it correctly and having to start from scratch reading up on how to write the codes. It's also vital that you do a statistical analysis at least twice to ensure there's no errors. And also the statistical advice and planning all the way through is vital to have somebody you can ask questions with to ensure that you're carrying out the analysis and interpreting them in the correct way. Ongoing work. There's several things to be aware about are that the NJR requires a yearly report and that you'll have to apply for an extension for the work every year to keep access to the data. Also, it's important to realise that whilst we come up with a clear plan, there may be modifications to the protocol that you have or changes that you want to make for further analysis. This must be submitted to the NJR for further review by the scientific committee. Writing up the project. It's really important that you plan the papers before you do the data analysis. And a small extra piece of information, once you've done that, could take hours and hours or even be impossible once you've done the initial analysis. It's also important to know the literature for what's out there and what you are adding to the current literature that's already there. Key tips. The first thing is to allow longer than you think. I think unless you've analysed large data sets, it's amazing how much extra time and effort it requires than you think it will do. The second thing is important to ensure you have a good team, to have good supervisors, and importantly, a statistician that can answer any questions that you have. Further thing is to develop the skills in data analysis and statistics early. This takes a long time, but is vital to ensure the accuracy of data and that you produce high quality results. A further thing is to go back to the start. You must have a clear question to answer. And again, a clear statistical plan with clear objectives so you know how to analyse the data and exactly what you want from it. So in conclusion, the NJR has a large amount of data that is absolutely fantastic resource to undertake research and projects. But using this data does take perseverance, planning and accuracy. And you must be prepared to repeat steps if there's uncertainty or there's an error in the data. One thing that can't be stressed enough is that you must allow more time than you think. Whilst all these things are quick to say, taking them takes months or even years to go through. Even learning statistical package and using it at the detail that you need to perform analysis takes a long time. It must be said though that using NJR data provides high quality data that allows high quality research to be performed, and it's an experience that I have learned absolutely massive amounts of knowledge from, and I would thoroughly recommend it for anybody who wants to use it.
Thank you very much, Toby, and thank you to all of the speakers today who have given their time to helping us make this webinar an interesting and useful opportunity for people who want to do research on the NJR data. So just if I can paraphrase and recap on everybody's talks, key issues are appropriate patient involvement at all stages of your application, appropriate planning. Planning is a recurrent message which comes through all the talks. When you're thinking about putting together your application, you want to make sure that the question you're asking is feasible, interesting, novel, ethical and relevant, and that you also consider take a PICO approach to your analysis, considering the populations, the intervention, the comparator and the outcomes that you're interested in. And a key recurring theme again is in preparing an application, take appropriate statistical advice and have that statistician involved in your application process, because without it, it's a much harder journey through to getting access to the NJR data. Okay, so now we're going to have a Q&A session for the remaining 20 minutes or so. So we have some questions that come up in the first question that I have that's come up in the chat is from Mohammed Mori, who says applications on the remote desktop do not include SPSS, which is a very commonly used analysis package. Can I still use SPSS if I have access to it? And I'm going to direct that question actually to Richard and Claire for their comments as to why SPS isn't in our package on the portal.
I don't know why it's not on there. It probably wasn't specified to be on there. Beyond that, I don't know.
I can probably give some practical advice there.
Well, I can tell you specifically why it isn't. It isn't on because the licensing fee to put SPSS on the data access portal was inordinately expensive, and given that Stata gives you at least the same amount of information for much lower license fee, that's why it's Stata that's on there and not SPSS, or both rather. Sorry, Richard, I didn't see you on the.
Oh, Mark, you beat me to the camera. Yes, that's right. It was just down to licensing costs. So that was the reason that decision was taken.
You'll also struggle to do the analysis with SPSS. It struggles handling large data sets like the NJR. So I think there is a practical reason for keeping with Stata and R and things like Python, as they're more suited to dealing with large data sets.
And the other point, of course, is that, you know, there's nothing that SPSS can do that these other packages can't do, and more. And an additional point is, if you have specific scripts in R that you'd like to run, you can ask for them to be uploaded to the system so that you can run them on the system. Okay, I'm going to open up for some sort of general questions now. So imagine that I was a junior researcher. I know it's hard. If I was a junior researcher and I wanted to, had an idea that I thought I might like to answer by the NJR, could I ask Toby or Jonathan to answer? You know, I have got no experience of the NJR and very little of research, but I've got a sort of burning question. Who should I speak to first as my very first port of call in trying to construct this into something that might be NJR answerable?
So I'll jump in. So I think the first thing is to understand who you're going to work with as a team. Have you got supervisors that have given you this question? And actually, from a very casual point of view, then actually asking someone like myself or Toby, who's got experience, what we can at least do is point you in the direction of what we found helpful, and how we went about it. And to be honest, that's exactly, I was in that exact position. I worked in a region that didn't have any experience of working with National Joint Registry data. And so I travelled up from Truro to Bristol to have a chat with Mike and Adrian, having never met them or spoken to them before. And they were very, very welcoming and did that with me. So I'd say the first thing to do is just drop a line to any of the existing fellows that you can see on the NJR website, and they'll be able to point you in the right direction. And with remote meetings now, it's even easier.
Yeah.
I think
I agree completely. For is a really good way to just communicating with them to find out what problems they've. So just communicate, just reaching out to people who've done it before, because there's lots of problems that we'll have all been through. So it's good to get their opinion. Also, as we've said lots of times, speaking to statisticians early to find out whether it is practical or not, the idea that you've got. And again, making sure that if you've got that idea, finding that it is something that hasn't been answered and there's a desire to answer it. So having a look about what research has previously been undertaken on the NJR website as well is really important.
Thank you very much, both. And so I'm still that junior researcher, and I've had a chat with Toby and John, and I've spoken to the NJR, and they've all been supportive. That this seemed like a sensible sort of question. How am I going to go about finding a statistician to help me? Where might I go?
Again, for me, from my point of view, the important thing that I didn't really understand as that orthopaedic trainee who wanted to do some research was how much the money is tied to people's time. And if you want someone's time to give you advice, finding a pot of money is always useful. But it's something that actually we very commonly have at the University of Bristol, and I'm sure all the other units will be much the same, is people coming to us saying, actually, I don't have a question, but I do want to get a research fellowship. I want to learn more about research. What can you do? And we certainly are always keen to talk with people, and we're mentoring a couple of people with fellowship applications coming up, and we can give them the advice. The other thing I'd say is it's important for people you need to involve statisticians, but you've also got to be able to speak their language as well. So finding short online courses to be able to understand some basic statistics is always useful. And I can certainly advise people of which of those courses I found most useful. But yeah, so in short, the answer is if you want to get a statistician's time, you need to think about how in the future you're going to pay them. So thinking about research fellowships. But again, talk to people who you know use this data frequently. And my email inbox is always open for any young researchers that want to think about using the University of Bristol. And I can be there as a filter to help people before they then go to Andy, Adrian or Mike, and hopefully give them a bit of advice best prepare.
Thanks very much. Very helpful answers. So I've spoken to my statistician, and I now find that he comes back to me and says, oh, well, you want to find out about this outcome in this particular group of patients, you need to access the National Vascular Registry. How might I go about that? So if I was a junior researcher and I wanted to link the NJR to say a vascular registry or some other registry that we're not particularly familiar with, and I've taken the approach of speaking to them, and they're getting a bit cagey about this linkage. Chris, if I could direct my next question to you, how might these linkages in practice be actually done, and who might make the linkage and hold the linked data set? Can it be the researcher themselves, or do we have to find somebody else to do that?
So typically not the researcher themselves, but really this is all driven by the legal basis for the data flows and how we set them up. So certainly it's not the case that it would be impossible for the researcher to broker those flows. It would just be more difficult and more time consuming. Generally, your best approach with dealing with non-standard linkages is to have early conversations with myself or with Rachel, because you might do one of these linkages in your career. I've probably done 50. You need to talk to people who live and breathe this stuff. So then what we would do is have a conversation. We'd try and find out what you want to achieve, which is a linked NJR vascular data set. We try and understand what can be done legally with the NJR data set. We try and understand what can be done legally with the vascular data set. And then we establish whether we need to put additional legal permissions in place, which we probably would. We'd probably need to set up a section 251 to flow both of those data sets to a third party broker. So I would suggest that the NEC would be well placed to act as that broker. So they would then link the data sets once we got the legal basis in place. They would then link the data sets. They would de-identify them, and then they would be able to upload those linked data sets or those linkable data sets into the data access portal for the end user to use. So it's an enormously complex one, but one that really benefits from an early conversation with experts on how to best deal with that.
Thank you. And Richard or Claire, do you have anything to add from the NEC side on how I might practically go about linking novel, unique data sets that haven't been linked before for this reason?
No, I agree with everything Chris said. I think early conversations are always helpful to try and sort of map these things out as early as possible. And as I talked about in my session, obviously, it also practically relies on having common data between the two data sets, typically things like NHS numbers. So I think also bear in mind that the effectiveness of the linkage will, of course, be based upon the quality of the data in the two data sets and the accuracy in which data is recorded in those two data sets. So there are some, even once you get over all the challenges of the legal basis and have all the permissions in place, you then get into the issues around the quality of the underlying data, and the quality of the linked data set obviously is going to be based upon how good the individual data sets are themselves, and having that common data identifier across them. So that's also a consideration.
Thanks very much. And just a reminder now to all attendees, if you want to ask a direct question, just put your hand up in the raise your hand in that function, and we'll identify you, and then we can unmute you so you can ask your question directly. Whilst we're waiting for people to ask questions, or if you don't want to raise your hand, you can put it in the Q&A section, because we're monitoring that still. So I'm carrying on this theme of I want to link my vascular and my NJR data registry for questions undefined. So I'm now thinking a little bit more. Somebody's told me that I need to link these two data sets. I know that feasibly I can link them. I'm now thinking about what the exact question I want to ask. And I'm kind of thinking that I need some public and patient involvement at this point, so that I get the real perfect question to ask the NJR. But I'm not, I haven't got any experience of PPE. Gillian and Robin, I wonder if one of you might be able to step in and guide my applicant to think about where he might get such advice.
Well, in the first instance, I would say that since an awful lot of joint replacement activity takes place with people with arthritis, there is a very active number of patient groups already available via Versus Arthritis, and approaches directly to the Versus Arthritis team on the web pages will be gratefully received with great interest. As you know, all of you that are surgeons, trainee surgeons, you know that Versus Arthritis has been supporting the build back of orthopedic surgery. We're concerned about waiting lists. There may be very active Versus Arthritis groups in your very area, so that's a starting point. What's your take on it, Robin?
I think it also depends what background the researcher is. If they're clinical, then there's a link in there through hospitals, so through colleagues. So they might be seeing people through outpatients. If they're not, then they can ask colleagues who have got more experience in that. We're increasingly finding that through hospitals and universities that there are PPI groups. You'll find that there are centres such as NJR biomedical research centres spread around the country, where it's a requirement they have PPIE groups, and they are then cross-disciplinary, so they're not just orthopedics, they're into rheumatology as well, so they're musculoskeletal. And you'll often find that you'll get patient groups, if you don't get them within orthopedics, you'll certainly get them within rheumatology, so you'll have established groups there. The ones to watch out for, if it's a researcher who is maybe not quite in that clinical, who may be coming from an engineering background, so they've got to either be inventive, they've either got to try and find some clinical people who they maybe know or maybe work with to ask them for advice, or there are other means. There are people who often will use social media. You'll often see that Twitter gets used by healthcare professionals and researchers, so they're trying to establish groups. Other ways, if they are within that clinical environment and they don't get to ask, or they're maybe not seeing patients, is they can put up posters and leaflets within waiting rooms within hospitals.
Okay, thanks very much. So I've consulted with my patient panel and other sort of interested parties, and we've decided that looking at failure rates of ankle replacements is a very important topic. And as I'm in a vascular registry linkage, I want to know about what the risk of amputation is following with failure of ankle replacements. And so now I'm thinking about a power calculation, because now I've got my defined question and it's a significant outcome of public interest. And if I'm doing I want to understand about predictive tools for what might be risk factors for amputation. Could maybe one of the statistical team jump in and tell me a little bit about the ratio between risk factors and event rates, to understand how I might create a model that will appropriately rather than overfit my data?
Yeah, I'm happy to jump in, Mark. So it's purely about your outcome and how often it occurs, what the event rate actually is. And so before they do the study, they have to actually go out there and find some data to understand what that might be. It could be from their local hospital. If it's quite a rare one, they just have to find some sort of data to estimate that. Then once they have that information, they need to then work out what size of difference they think is important for that outcome. There could be a relative or absolute effect. Is it 10%, 20%? What difference might that be? And then according to how rare that outcome is, so say only 10 patients have that outcome, you have this thing about 1 degree of freedom in your model to every 10 outcomes that occur as a rough estimate. So there's a need to consideration about model overfitting, but ultimately it's just trying to think about what size of effect, like a hazard ratio, can they detect given that outcome event rate. But that's the start point, just work out what the outcome is, how common it occurs.
Okay, so if my outcome, say, happens 50 times in every 100,000 patients, how much scope do you think I might have for identifying predictor variables? How many predictor variables might it be reasonable to include in such a model?
I think it really depends on the type of event that you're having. So that you might find actually, for example, that if your events occur very rarely, there is one very strong causative factor that predicts those. And if that's the case, then you're only going to need one explanatory variable. If you take it to the absolute extreme, so if you've got 50 events and you have 50 explanatory variables in there, and those 50 variables are evenly unique to those 50 events, you can make a perfect prediction. It's completely meaningless though. So you have to make this balance between having lots of explanatory variables and having a number of explanatory variables that are proportionate to the thing that you're asking. So it really is quite, I would be concerned if you had 20 explanatory variables for 50 events. I think you would probably more want like 50,000 events to have something that precise. I think in terms of overfitting, it's you have to think just very generally in relation to, you know, the type of models that you're fitting. So for example, if you have age, you may say there's roughly a linear effect or maybe a piecewise linear effect, and that may be reasonable. But if you have a 20-degree polynomial for age, the answer would be it's probably overfitted. And if you're not quite sure what a 20-degree polynomial is, it would be a very bendy little line that you might be able to fit to age because the NJR dataset is so big, but it would be practically useless for making any generalization to, or wouldn't replicate when you next did an analysis.
Okay. Mark, I think it comes as well to think why you're doing what you're doing. I mean, think are things biologically plausible, or are they just there because there's lots of different variables and you find one every now and again? And think what you're trying to do. Are you trying to create an output that's going to inform a risk discussion with the patient, or are you actually trying to change those outcomes for patients, so modifiable and non-modifiable risk factors? All those things can really influence the path you go down on. And I think the temptation is always to include too much into the models and not rationalize early enough.
I think there's an old adage which says all models are useful, but all models are wrong. And I think that's quite correct. You always have to remember when you're doing statistical analysis, you're making a model and it's a simplification of reality. And you want to make that simplification to be not unduly simplified, that it's not useful at all, but there's a balance.
Great, thank you very much. So I'm conscious that we're just about out of time. So just before we finish, I want to pursue this scenario a little bit further. So I've decided that I've got my model, it all seems to work. I'm writing it up now and I want to publish it. So I've got my finished manuscript. Rachel, can you just recap for us again what the steps are once I've got my final manuscript? Do I just fire it off to the journal and see what happens, or what are the conditions?
Not quite. So on our website, we've got our acknowledgement document here. You'd find the suitable acknowledgement to put into your paper. Then you send it through, well, you make sure all authors are listed, then you send it through to myself or our generic research email address, so research@njr.org.uk. And then I will send that around to the research committee, who have 10 days to comment on the paper. So I'll let you know of any comments in that time, or give you the go-ahead to submit that for publication. And also Deirdre is then involved if you need any sort of assistance with any press release following publication. And then just please let me know once you do have confirmation of publication.
And so, Deirdre, we're talking about communicating this piece of original work to the masses. Anything the NJR can do to help us publicise our work and make it more widely available?
Well, yeah, as Rachel's mentioned, we can support with any sort of press release advice. And if you send it and you need it to be a bit polished, happy to look at that and do that too. We can also promote that it's gone live on our social media channels, especially Twitter, which obviously is quite a good way to reach a lot of other clinicians and interested researchers and patients as well. So yeah, just disseminating it as widely as possible in some of the ways that I described earlier, we can support with. And we're just about to make our new website go live in the next few weeks. So there'll be plenty of scope to carry some of the research. I think we should produce a template where we can put things in a very consistent way on the website to demonstrate the research that we're doing and to show how we're using such valuable patient data information.
Thank you. And just a final comment for Amar. Any thoughts and suggestions in respect to the fellowship programme for prospective shoulder surgeons who might be interested in using NJR data?
Yes, I think there's obviously quite a lot of data to mine still and to get some meaningful information from them. There is another fellow who's actually starting in Oxford with Johnny Rees, who's going to be doing some of the shoulder analysis. The bit that's not yet done is analysis of elbow data, and that might be something that might be quite topical as well because of the imminent GIRFT-driven reconfiguration of elbow networks nationally. It's something that might help provide more information to try and analyze what's happening currently in terms of baseline, and then have a further analysis following reconfiguration of the networks to see what happens to the data within the NJR in terms of how the reconfiguration has worked and also the outcomes from that. So there's certainly quite a lot of work that can be done with NJR data. So fellowships going forward in the various subspecialties would be particularly attractive for trainees, I would think.
Great, thank you very much, Amar. And I'd like to extend my thanks now to all of the panelists for all their time and effort and contributions to this webinar, and particularly to Rachel Brophy, who set the whole thing up, organised it seamlessly, corralled us all together to give our presentations in time and got us organised to deliver it today. So thank you very much, Rachel, and thank you to everybody. This concludes this NJR-led research webinar on accessing the NJR data. Thank you for your time and interest.